Thank you, Dr. Chandan. Respected friends, colleagues, indeed an honor to come to Ranchi and participate in Bihar Jharkhand ISG-Con. We aim to upgrade the academic discussion and carry on with this. I'll be speaking on recent advances in IBD. So just a brief introduction. IBD, that is Crohn's, ulcerative colitis, indeterminate colitis, and unclassified colitis. As we all know, UC primarily targets the colon and CD can affect any part of the GI tract. UC can be proctitis, proctosigmoiditis, distal disease, or pancolitis. CD can be inflammatory, stricturing, or penetrating, and also a subtype of perianal CD. Age and sex can influence the incidence and prevalence of IBD, and about 25% of them can be seen in cases of pediatric cases as well. These are the types of CD which I just mentioned: ileocolitis, ileitis, gastroduodenal jejunoileitis, where colitis, it can be mainly skip lesions and perianal. UC, as mentioned, can be proctitis, proctosigmoiditis, and distal, extensive, or pancolitis. These are the salient features of Crohn's disease. That is endoscopic features: cobblestalling, serpiginous ulcerations, aphthoid ulcerations, segmental involvement with skip lesions, healthy mucosa is intervening them, stenosis, fistulas, and typically rectal sparing. Whereas in UC, we see that the rectum is usually involved. It is a rectal origin with proximal progression. The inflammation is usually diffuse with no normal mucosa in between. And if we have extent proximal to that, usually the mucosa will be totally normal. The mucosa may be erythematous with loss of vascularity, friability, ulcerations, and spontaneous bleeding. In treated cases, we may also see pseudopolyps. So what are the goals of therapy over here? Early diagnosis is the key to achieve long-term remission. Rapid induction of remission is also very important, which can be both clinical as well as mucosal. Stable and sustained maintenance of remission, that is prevention of relapse and maintenance of mucosal healing. Prevention of complications, both disease related as well as drug related, that is vaccination of the patients, uh, screening for colorectal malignancies, and to try and decrease the hospitalizations and incidence of surgery in them. Manage the psychosocial comorbidities, depression and anxiety. Sexual dysfunction should be actively sought in these patients and addressed. Cost effective care uh, is very important, because if it is not so, patients tend to default, and that leads to poor outcomes. The dynamic treat to target in IBD is: immediate is symptomatic response, and intermediate will be symptomatic remission along with CRP normalization, and fecal calprotectin usually we aim to decrease to acceptable range. And endoscopic healing along with quality of life normalization and absence of disability is a long-term goal. And in children, we should aim for the normal growth patterns. In This is an ideal scenario that in Crohn's disease we should aim for transmural healing. This is again a chimera which is not easily achievable, and in UC histologic healing, which is usually better achievable in them. So, what are the targets? We have clinical targets and biomedical targets, biochemical targets, which I have already mentioned. Endoscopic targets I have mentioned. And finally, the molecular targets are the future perspective, which we aim to address today. Agents which are used for treatment of IBDs, traditionally steroids have remained the mainstay along with aminosalicylates and immunosuppressive, that is azathioprine 6-MP or methotrexate. Immunomodulators can also be used as an adjunct with anti-TNF therapies. Small molecule therapy options, TNF inhibitors, which is adalimumab and infliximab, certolizumab and golimumab are also available. They can be used both for achieving induction and achieving maintenance therapy, both in CD as well as UC. Integrin inhibitor, which is also being used now, vedolizumab, again can be used both for induction and maintenance, both in CD and UC. It is licensed in both. And IL-12/23 inhibitor, that is ostenicumab, again licensed for both CD and UC for both induction and maintenance. Small molecule agents which are still not available in India, that is S1P modulators, ozanimod. However, JAK inhibitors are available now. Tofacitinib, which many of us are using, and opadacitinib, which is still not available in India. So tofacitinib has good response, but it is not licensed for CD, only for UC. Conventional maintenance therapy, as I had mentioned, are mainly the 5-ASA, mesalamine and sulfasalazine. Antibiotics may be used as and when required, with steroids for the flares which occur, and immunomodulators for long-term therapy. Uh, 5-ASA is mainly for mild to moderate disease. However, we should be very liberal in using immunomodulators in moderate to severe disease. Most conventional therapies have not been shown to be effective for induction of maintenance. So we have to look for various other kind of therapies now. Now, just overview of 5-aminosalicylates, various types are available. I'll not go into those details. But suppositories and enemas, which are not being used as often they should be used, they are very good in this. And usually it gives the local delivery of the drug much better than the oral ones. Steroids, various ones, either hydrocortisone for acute flares, methylprednisolone, or prednisone, oral prednisolone for intermediate or long-acting ones. Budesonide is being used mainly for Crohn's disease. However, many adverse effects have to be kept in mind. Immunomodulators, azathioprine, cyclosporin is being used. Now, tacrolimus is also available both in oral as well as rectal formulations. We should screen for certain infections which are likely to flare up while we are giving immunomodulators. That should be kept in mind. And adverse effects, of course. This is a group which is yet not being used in India extensively. However, this can be used for moderate to severe UC and as a oral therapy. Biologics have become very, very important in management of IBD. They are biologic material as by this thing, and they are monoclonal antibodies, and they have revolutionized the treatment. The three main groups are anti-TNF agents, anti-integrins, and IL-12 and IL-23 antagonists. Early, the common approach was use 5-ASA, antibiotics, prednisolone, followed by immunomodulators, and then possibly the biologic, which is traditionally called the step-up approach. This delays achievement of mucosal healing and allows natural progression of IBD, which leads to more severe complications. Ideal approach would be start with 5-ASA steroids and immunomodulators and accelerate the use of biologic agents as soon as possible. This helps in achieving early mucosal healing and affects the natural progression as well. So anti-TNF, both infliximab and adalimumab are very commonly being used over here in India. And infliximab has been around for a very long time. Adalimumab is been available for last about 10 odd years or so. And it's been available as a subcutaneous injections. This is the adalimumab monoclonal biosimilar, which is available in India. So before initiating biological therapy, obviously we have to screen for occult tuberculosis. We should screen for fungal infections or bacterial infections, HIV, HPV, and any other localized infections. This is the suggested dosage for adalimumab. Induction dose 3 doses, and followed by maintenance dose. The maintenance dose recommended is 2 years. This is one of the first trials in India, which was a multicentric from AIMS, HGPGI, from the Dr. Sood's group in Ludhiana and Fortis in Gurugram. And they had about 70 odd patients, mainly 49 CD. and they had good response to some patients in infliximab failure also, and they had a good response to adalimumab in this study. Effectiveness as well as safety profile was there. This is what we had done in Delhi. This was the single center study, and we tried to see the steroid refractory, difficult to treat UC patients we recruited for the study. And we also tried to see whether these patients can be from the traditional dose of every 2 weeks maintenance. Some patients who can be given for every 4 weeks. We had 25 patients in them, and we could achieve clinical remission by week 12 and maintain the clinical remission. There was no colectomy required, and steroid free remission was almost up to 60% in our group. Safety and efficacy was very good in our study. Vedolizumab is again integrin blocker. It is indicated for adults, not licensed in pediatric age group for severe UC and CD. It is gut specific only, and it cannot manage the extraintestinal manifestations. So again, it has to be given two doses as induction doses, followed by 8 weekly maintenance. The ustenicumab, which is IL-12/23 dual blocker, and IL-23 blockers, various other monoclonal antibodies are there. They can also be used. Ustenicumab is being used in India extensively. In Crohn's disease, basically low risk patients are who have just terminal ileal involvement or proximal colon involvement with minimal symptomatology. So they can easily be managed with budesonide or tapering courses of prednisolone with or without azathioprine. In moderate to high risk patients, we should always consider the biological agents with or without addition of immunomodulators. For high-risk Crohn's disease, infliximab, adalimumab as an induction is a preferred mode as a monotherapy along with either azathioprine or budesonide. For mild to moderate ulcerative colitis, medication choice 5-ASA is the mainstay along with either budesonide or azathioprine. Rectal administration for distal disease helps in symptomatic as well as disease remission. This is for induction of remission in moderate to severe ulcerative colitis. Both TNF inhibitors, that is infliximab, both vedolizumab, ustenicumab, all can be used. Tofacitinib is easily available now, and it is approved for TNF naive patients, usually not for TNF non-responsive patients. In severe case, you can, this is the algorithm for selecting the biologicals which you may do in a severe IBDs by various subpopulations. Things to note over here are patients with extraintestinal manifestations. TNF inhibitors or tofacitinib are the only ones which do help. And previous TNF inhibitors failure, we can go to tofacitinib or ustenicumab. Adverse events, we common and rare ones are there, and we should be always aware and try to manage them. Usually most of them are managed, but things like disseminated tuberculosis require stopping of these drugs. So summary of choices for pregnancy, failed anti-NF therapy. Some indications are given, but then you'll have to tailor the choice as per the patient. And the most difficult to treat Crohn's are the Crohn's disease patients, especially perianal ones, and small bowel disease. FMT has come up in a big way in treatment of IBD, and as gut dysbiosis is known as a causative factor in causation of IBD, so FMT does help in many chronic cases and should be considered. FMT is not a very difficult thing to set up now, and I suppose all of us can do small FMT trials in few patients. So just to summarize, uh, I have discussed about what are the types of IBD, the goals of management, the conventional therapies and what the things are lacking in conventional therapy, and what should be our approach to biological therapy, the anti-TNF agents, the various other monoclonal antibodies, and a bit about the fecal microbiota transplant. Thank you very much. A very nice way of looking at it. Um, as most of my colleagues will agree, the intervention of surgeons in IBD, especially in UC, is becoming less and less. We have the armamentarium to manage almost all of them. The old Oxford regime of acute severe colitis, where after 3 days, if you give the intensive therapy and it doesn't happen, you send the patient for total colectomy. So I am sure most of my colleagues will agree that it's hardly being practiced, and we are being able to manage almost all cases of either refractory or even steroid, poorly steroid responsive UC. Uh, Total colectomies can be either because of complications, either perforation, severe bleeding, but poor response to therapy usually is very, very low down on the cards now. इसमें one thing which I'll request you to consider is whether the compliance of the patient is good or not, whether we have reached the maximal doses of drugs or not, and whether we need to use, uh, I mean, other than the recommended doses of monoclonal antibodies, we can step up the doses of monoclonal antibodies. That can also help in managing many, many refractory diseases.
Thank you, sir. I think we have to maximize medical management, and if it's not responding, compliance is okay, then we have to think of surgical.
Usually, that is, I mean, I have not seen any such case in my practice. If anybody has, I'll request them to share their experiences on this. Yes,
Yes,
Dr. Chandan wanted to
actually,
say
I had
something.
a similar case. That's why I was
Okay,
asking. I
okay.
was in Noida. One case was there. I was giving mesalazine, full dose, steroids, azathioprine, and later on I switched over to this
Infliximab.
infliximab also. Initially, she responded well, but after 1 or 2 months, she was getting again bleeding PR. Then I asked the surgery consultation, but they were also not very keen. Then somehow the patient responded well. I added some tofacitinib in that also. So I don't know whether that worked or the patient was compliant with the medications. So I
Many a
think
times patience does work, and what happens is the disease natural history is also of flares and remissions. So we also have to keep our patience, and maybe 1 2 months is a very short time in a chronic disease like UC to make a decision for surgery. Any comments, Chandan?
She was a lady of 45-year female from Jharsuguda, and she had a chronic history for last 5 to 6 years on alternative medications. So initially, before COVID in 2019, he came and we did induction with adalimumab, Adafrar. She responded well. Then in COVID, she came with the flare. After 1 year of completion of biological, patient declared remission free, histological remission to be followed up. But after during the COVID, she again had a flare. And then we don't know exactly whether it was a CMV or COVID itself, and patient landed in toxic megacolon. There was a restricted medical resources also. Residents were in COVID ward. So I was following her strictly from the day one. So I think on the day 7 of toxic megacolon with conservative management of everything we have given, including everything, she didn't responded and sepsis was ongoing. Despite repeat induction with first adalimumab was given, then again we switched to some infliximab. No other alternate to anti-TNF was there at present. And then finally we have to go for plan colectomy. to the patients.
That is a very classical case where you will request the intervention of a surgeon.
Yes, sir.
And recently, I had a case who was under my follow-up, but went for a follow-up somewhere outside, and during colonoscopy had a perforation. So underwent a total proctocolectomy. So yes, surgery is certainly not out of the question, but I would say that it is becoming less and less recommended.
Since the introduction of these biologicals, now requirement of surgery are very few. In last 10 years, 3 of my patients underwent surgery. Those are either biological failure, that is very uncommon nowadays. Second, if the patient is not affordable for biologicals, then, and since the introduction of this oral drug, TOFA,
Mhm.
now it's, I think, very uncommon this surgery. So now surgery very uncommon. If you want surgery in a small centers, usually patients do not accept surgery in the special scenario that like toxic megacolon or perforation, unexpected perforation. These are the emergency indication for surgery. Otherwise, yes, surgery is the choice in biological failures. Second question, sir, one question, the what workup before starting biologicals? Because one of my patient last week I just encountered, he is a police inspector in Ranchi and severe ulcerative colitis, admitted, responded to steroids. Now we just done TOFA because he was intolerant to azathioprine also. Now patient suddenly came after 3 months with abdominal distension, gas. I thought something is there. Then I go for CT1. Again he visited it's constipation. First I thought it's constipation. CT ascites workup done. It's tuberculosis, ADA high. So what workup will suggest before starting biologicals?
This is something like the holy grail. I mean, whatever workup you do, you will end up having tuberculosis in some patients or the
Yes.
other. I mean, there is no such thing as zero
Because
risk.
routine tests all done in this patient.
Zero risk kind of a scenario does not exist in this. Various things we have done earlier. I mean, during our residency days, you would also have faced. We used to just do X-ray chest and maybe a Montu test or something like that.
Just I wanted to know whether the steroid is responsible or TOFA is also responsible for this
TOFA
tuberculosis.
is also responsible. I would say it is more responsible than the steroids in causation of flare of the occult tuberculosis. Even if after we have done the CT chest, IGRA, all those things, in spite of that, almost all of us would have had some experience of flare of tuberculosis in some patients. So you can, I would suggest, do a test with CT chest. You go for the IGRA for tuberculosis. Uh, Montu or skin test may or may not be done because it does not carry too much of a value. And in some patients, it is nowhere mentioned, no guideline mentioned it, but some people have used INH prophylaxis also while giving biological therapy. But it does not exist in any guidelines, and most experts do not agree that you give INH prophylaxis. But these are the only options. But in spite of that, if you give enough biologics, I'm sure all of us will face sometime or the other flare of tuberculosis.
And your series of Crohn's patient that
Yeah,
was shown in your paper,
yeah.
what is your recommendation? If you put the patient on biologicals, would you continue with 5 SA, 5 ASA for maintenance?
I have continued 5-ASA, though 5-ASA is not known to be very effective in management of Crohn's or to reduce the incidence of complications in Crohn's. The only thing which helps over there is possibly azathioprine. Azathioprine with steroids as and when required.
Logic behind continuing in unresponsive ulcerative colitis, even ulcerative colitis not responsive to this 5 ASA, you switch over to AJA or
Yeah,
biologicals, even though you continue because
yeah,
for cancer chemoprophylaxis,
yeah.
because 5 ASA is known. But
5-ASA is there.
Crohn's cancer is very rare. So I'm just asking particularly in Crohn's disease.
Most of us, by dint of habit, have continued.
But
But
the
I'm
burden of cost.
burden of cost is certainly there. You are very right about it. But it's old habits die hard. That is why we are continuing it. But no evidence exists of continuing 5-ASA.
My last question, the current scenario, Indian scenario, what would be your approach? Step up approach or step down approach? Means start with biologicals or go up if affordable?
In an Indian scenario, I don't think we can have that accelerated step up approach.
Yes, sir.
We have to be conservative about it. And traditional step up approach is what I have followed in my practice. And I would still recommend in a resource constrained setting. In fact, our study, when we started, we were trying to gather the steroid refractory and see the effect of adalimumab. But when some patients, or in my setup at the time, availability was an issue, because although government was giving it, but sometimes funds would not come, sometimes the medicine was not available. So we decided that a subgroup of patients who are doing well, we will increase the duration between two doses and see whether they continue to respond or not. It's something like using in alcoholic hepatitis, you see the Lilly score at day 7, and then decide how long to continue the steroids in alcoholic hepatitis. So similar is the thing which we thought in our study, that whether we increase the dosages or the gap between the two dosages, and whether they maintain remission or not. And this is the time we realize that a subgroup of patients do help in even effectively, we have reduced the dose by half, but still they were able to maintain remission. So recommended dose, you can use your judgment in certain patients. You can reduce the cost, and that is why you can use certain biologics for in a reduced maintenance dose for 6 months to 1 year. Or if you are using reduced dose, you may be able to give maintenance for much longer, which will be much more beneficial to the patient.
Yes, sir. Thank you.
Yes.
What are the opportunistic infection you have encountered apart from tuberculosis?
Most commonly, it is tuberculosis only. Otherwise, we have seen CMV is there. We have seen flare of hepatitis B. It was HBsAg negative before starting that, but became HBsAg positive, IgM anti-HB core positive. These are the three scenarios which I have seen.
So CMV per se is tagged as a bystander in IBD.
Yes, it is. So, however, if you are on colonoscopy, you are seeing ulcers which are not typical of IBD. CMV, DNA is positive, as well as biopsies, you are getting ghosting. These are only two cases which I have seen
So
in my.
before starting biologicals, it is mandatory to go for
No,
well
no. Even if you do CMV serology, or CMV DNA is very expensive to do. CMV serology will be positive, and based on that, you cannot say that I'll not give IBD biologics.
So when
It is
prophylaxis is mandatory in that case.
CMV. CMV, as you rightly said, is a bystander. So how do you decide whether the based on CMV, whether you will give biologics or not give biologics? But flare, if it is occurring, I've never stopped biologics in CMV flare. I've treated CMV. That's all I've
Okay.
done. Thank you.
So it was a very extensive and comprehensive talk on IBD. We get a deep insight and very a nice talk. Alright. So thank you, Dr. Alok Chandra sir. We are moving ahead in our academic phase, and so now our next speaker is Dr. Satish Midha sir. Uh, what will be very small for his contribution in the academic field. So we have a long list. So in brief, he is president of Indian Association of Gastrointestinal Endosurgeon. He is ex-president of Indian Medical Organization with ex-honorary secretary of Indian Association of Gastrointestinal Endosurgeons, ex-president of Hemophilia Society Ranchi, ex-president of Academic Forum Ranchi, and many more yet to come, sir. So long list is there, and we are very blessed to have Dr. Satish Midha, sir. With a request of single call, he is ready to give insightful lecture on robotics in present era. So I shall request, please, Dr. Satish Midha, sir, to give an insight talk.
Good morning, everybody. Thank you, Chandan, for your kind introductory words. When I was doing my post graduation in general surgery, at that time, a revolution in surgery came. That was laparoscopic surgery. It's almost 3 decades now, and this is the another revolution in surgery, which has almost come because more than 300 installations of robots are already in India. And I think 5 to 10 years down the line, most of the surgeries will be performed by robotic surgeries. Of course, with the surgeons, not the robots will be performed, but we have to go ahead with this. Though most of you are physicians here, I am one of few odd men out. When I started these procedures, then at that time I was rather forced to learn many of these therapeutic surgery, endoscopic procedures which were not being done at that time. Most of you are not here, are not joined Ranchi. So this is how my journey started. Now coming to the robotic surgery, we will go through different about the robots, how these things have advanced, especially the Da Vinci robot, which is the most vulnerable one used being throughout the world, but now many Indian uh, features have also come. Robotic surgery is a mechanical help where provided to the surgeons, and we control the robots either by remote control or by voice activation. Using robots in the operating room is to assist the surgeon in performing surgery. Surgeon views the patient via a terminal and manipulates the robotic surgical instruments via the control panel. Views of the organs being worked and are transmitted from a tiny camera inserted into the body. We have already seen how the robots have changed the manufacturing of cars and other consumer goods by streamlining and speeding up the assembly line. In the coming decades, we may see robots that have artificial intelligence. Some, like Honda's SMO robot, will resemble the human form. When we talk about the robots doing the task of humans, we often talk about the future, but the robotic surgery is now a reality. Doctors around the world are using sophisticated robots to perform surgical procedure on patients. While robotic surgery systems are still relatively uncommon, several hospitals around the world have these systems, and potential improvements are going on. The major advances aid the surgical robots have been remote surgery, minimal invasive surgery, and unmanned surgery. The history, going to the history of developments of robots, in 1985, Puma 560 was used to place a needle in the brain biopsy using a CT guidance. In 1988, Robot developed the Imperial College in London. The Robodoc from Integrated Surgical System was introduced in 1992 for hip replacement. The first unmanned robotic surgery took place in May 2006 in Italy. So basically, there are three types of systems: supervisory control systems, telesurgical systems, and share control systems. Supervisory control systems, these are most automated ones. System follows the specific set of instructions. Surgeon input data into the robot. There are 3 steps in progress which include planning, registration, and navigation. Planning includes mapping patient's body to the computer, and a pathway is determined. The surgeon finds the points on the patient body, and then the navigation is done. Surgeon activates the robot. Coming to the supervisory control systems, there are 3 types of telesurgical system, which is the most commonly used robot nowadays. There are 3 types. Da Vinci, who is the pioneer in the laparoscope, they have the maximum installations throughout the world. Then the Zeus robotic system and ESOP robotic surgical systems. Da Vinci has two primary component system. One is the viewing or the control console, and second is the surgical arm, which could be 3 or 4 arms. And the arm consists of camera with 2 lenses, and we get a 3D image. So this is what the surgeon sits on the console, and these are the arms. Now, in this, we see that there is a one head, and there are 3 to 4 arms, and now there are sets in which there may be different arms, not under one big unit. The JS surgical control system is made up of an ergonomic surgeon's control console, the 3 table-mounted robotic arms, which perform surgical skills and provide visualization during the endoscopic surgery. It is similar to Da Vinci surgical system, provides voice control capabilities, and performs complex microsurgical tasks. ASOP surgical system employs the assistance of automated endoscopic system for optical position. ASOP was the first robot to be cleared by FDA for assisting surgery in operating room. It is an automated endoscopic system, much simpler than Da Vinci and JACE, positions of the endoscope for a surgical camera. Then coming to share control robotic system, use of concept of there is a active constraint. So defining regions of the patient safe, closed boundaries are forbidden, and surgeon concentrate on the safe regions. Coming to the software architecture of these robots, presently systems are based on Linux or 64-bit platform, MSQL as the database, and Coin 3D for viewing the 3D models. This is how the uh, robots have developed. So Da Vinci has also progressed. Now these are the 3 old versions. Now XI system has come, and every time more and more instruments are being incorporated. So the surgeon controls the robotic arms. There is a 3D HD vision, which is more than the laparoscopic vision. The most advantageous thing is the endorist instrumentations. We have, as human beings, limitation of movements. The maximum we can rotate is 180 degree, but these robots can move up to 360 degrees. There is intuitive movements, motion scaling, filtrations of tremors. So when laparoscopy came in, the most of the advantages went to the patient, but surgeons has to struggle a lot. There was a long uh, learning curve, and many of the ergonomics factors came. Some of the surgeons developed back pain, neck pain, shoulder pain. All these factors were there. But when robots will come, the surgeon will sit on the console, and the movements will be of only the wrists and the fingers. So there will be no strain on the body. So our precision will increase, and we will be able to give better results. And it replicates high standard of surgery every single time. The first robotic surgeons, they have been already been manufactured, and many more units are being installed. Da Vinci were the pioneers in the basis of dexterity experienced on the open surgery relies almost on the unlimited wrist, elbow, and shoulder degree of movement. The surgeon has to move around the fixed ports. In order to solve these limitations, tools have been developed that have an articulation at the tip, which increases the degree of movements. Addition of the wrist at the tip of the instrument gives tool manipulation, which is much more complex. Computer assistance is warranted as the human brain cannot efficiently manipulate articulated instruments by mechanical means. So this is the setup. We have one assistant surgeon there. Sometimes we used 1 or 2 extra ports, which are non-robotic arms, like for suction or clip applicator or thing. But most of the dissection part, suturing part, and the complex surgery, especially the uh, uh, metabolic surgeries, surgeries for the cancer, difficult procedures like Whipple's procedures, all these procedures are being done by robots nowadays. And it's more accurate and more precision than the laparoscopic surgery. Coming to why robots is not a machine, it is an informative system with arms and which is more accurate than the human beings. So these are the degree of movements which can occur with the robots. And now remote surgery is being done, uh, and even the SI mantra, which is the Indian version of the robotic system, they have recently performed telesurgery from a different the time lag factors and all these things. They have also been corrected, and so many of these procedures can be done with use of robots. Da Vinci is the most advanced system, and these are the parts of this robot: surgical console, patient side cart, and instrument imaging processing unit. This is how the instrumentation are set, and surgeon has the optical hand-eye instrument, and there is a 3D stereo viewer, comfortable seat, motion scaling, and tremor reduction is also there. Then there are different instruments which can be used. One is the camera arm, and there are different instruments. These are available. The only thing is that they have a fixed life. There is a count after which these instruments will not function. So at present, each procedure will add about a lakh of rupees for the patient. So whatever we are charging 1 lakh for Da Vinci's or 50 to 60,000 rupees for Indian uh, unit. So that will be the extra. Many disposables are also used. So these are the specialty. So the patient has to move his fingers, and simultaneously same movements occur in the robotic. ठीक है, चल गया. So this is just a animation video of the Da Vinci only. The surgeon looks at the console. The first thing is the docking of the robots. So these uh, uh, insufflation is done, and these are usually 8 trocars which are put in place. Docking usually takes earlier that was a thing which was a controversial thing, that docking takes a lot of time, but nowadays with practice it can be done in 3 to 4 minutes also. Once the docking has been done, these are the only movements required by which we can manipulate these instruments. But learning curve is not that steep. If one has the equipment, in I think in a fortnight or so, he can master the techniques of suturing. So, but again, there are some physics involved in it, placement of ports, because sometimes many accidents have occurred also. These robots may hit on the patient head or something like that. Sometimes even few deaths have been also reported if the instrument has not been properly used. So these are the some of the things which we have to keep in mind and we have to learn. So these are the movements which can occur. So, but overall, our movements become precise, and things which were difficult operating in, like doing surgery for the prostatic cancer, esophageal cancer, which are deep down, they can be easily done with the help of. So in laparoscopic surgery, one has to learn a lot to master the suturing techniques, but it can be learned easily. Some of the surgeons who have not done laparoscopy have gone directly from open surgery to robotic surgery. Uh, but going from laparoscopy is easier. So this is how the docking is done. The whole set, whole the instrument cart comes in, and the instruments which are required, they are attached to it, and then the procedure can be done. And surgeon has the control over the all the gadgets, including diathermy, monopolar, bipolar, now even harmonic and other instruments have been also been incorporated. So all the complex surgeries can be done, including cardiac, neuro, many of the procedures are being done by the robots. So these are the applications starting from cardiac, GI surgery, gynae, neuro, orthopedics, pediatrics, radiosurgery, and urology. We all know the advantages. These advantages are reproducible of laparoscopic or the minimal invasive surgery. The incision is less, pain is less. Even the pain scores compared to laparoscopy are better, and post-hospitalization stay and recovery is swifter. And the incisions are smaller, and it overcomes the limitations of human wrist, reach inaccessible areas with ease, work in the limited space, and no risk of the transmission of disease because we are away from the patients. Only system that allows surgeons to operate while seated, better ergonomics, reduce surgeon fatigue, and minimal invasive approach even in the obese patients. For patients, again, these are the advantages which we have already discussed. So now more and more procedures are being adopted, like radical prostatectomy, cystectomy, nephrectomy, pyeloplasty, cardiomyotomy, colectomy, adrenalectomy, pancreatectomy. So it facilitates successful completion. Gynecological oncology procedures can also be done. So there is enhanced view, easier to attach nerve endings, surgeons tire less easily, fewer doctors required in the operating room. In term, it is cheaper to the hospitals in the long term, a smaller risk of infection, less anesthesia required, and very less loss of blood. Again, there are safety issues which has to be addressed. I think, but later on, these guidelines and protocols are being developed. There is some ethical issues also which needs to be addressed. Legal and ethical issues. If something happens, who will be blamed, surgeon or a robot? Time lag, I think this is now almost being corrected. Sometimes these power failures and etc. and but does not replace the human intelligence, skill, and the experience. And surgical robots are much costlier. Da Vinci will cost about 16 to 20 crores in Indian rupees, but Indian robots are around 6-7 crores. This is the SSI Mantra robot, which has been launched by one of the cardiac surgeons in India only, and it has been accepted throughout the world, and many units are being established, and they are good in doing the research and R&D. They are very fast, and they are adopting more and more instrumentations also. To conclude, the rate of discovery of new technology is outpacing the ability of business, society, and healthcare to integrate and apply. Robotic surgery is but one example of such technology that may reduce operative morbidity, hospital stay, and recovery while potentially improving clinical outcomes. But at what point do the benefits justify increased expense? That is again a controversial thing. Thank you very much. Many of you are not surgeons, but even if you have surgeons colleagues, I'll be contesting for ASI president this year. So I need your kind support. Thank you very much. Though robots are not available in Bihar, Jharkhand till now, uh, but still we hope that next few years they will be there. Uh, we are conducting. I am the president of IAGS, and we are conduct so many false courses, advanced laparoscopy courses. The last year, hernia was the best choice for surgeons, but now the trend has changed. Means more and more robotic courses are being demanded. So people want to learn it. Even the postgraduates or just those senior residents who have just passed out, they want to learn this technique. There are there is a society, ARIS Association of Robotics Indian Surgeons, something like that, which has collaborated with the Royal College of Surgeons of Edinburgh. They conduct 1 year course, and there is a module for which we have to attend few, and probably they have also got some certification from Ramchandra Medical University in Chennai. So there's a one thing, but again, nowadays the only thing is once you want to learn it, you have to get the equipment. Once you get the equipment, the industry will train you because Da Vinci has the training module also. Means you have to pass those tests. There are tests also in, then only you can go for the human practice.
Thank you so much, sir, for better insights to the name mind for the robotics. We expect robotics for ERCP in near future.
There are platforms being developed for the endoscopic robots also. And I think they will also, because notes was started earlier, but
Yes.
more didn't pick up. But some industry, they are trying to have develop platforms with the endoscope also.
I think poem will be the first procedure that will be done by robot. Let's hope. EMR, third space. Third space is more of a surgical ERCP. So we have a 10 year of lag period for young generation. So moving ahead, so I request Dr. Emil Prasad sir, additional professor, Department of RIMS Ranchi, to give an insight talk on shall we moving ahead. So I request Dr. Pranav Mandal sir. Uh, he is Director Gastroenterology, Samford Hospital, one of our senior gastroenterologists in Ranchi, and we have learned a lot from his experience in past also. So I request him to please give insight on management of renal failure in cirrhosis. So handing over mic to Dr. Pranav Mandal sir. Sir, please.
Good morning, respected seniors and dear colleagues. My topic is management of acute renal failure and cirrhosis. Recent update. As you know, that acute kidney injury is very common in cirrhotic patients who get admission, and it's very important to timely diagnosis of acute kidney injury and characterization of type of kidney injury, because it of utmost importance of the management, because it depends on the what type of kidney injury patient is having, and the timely start of the treatment determines the outcome of the patients. So, what are the learning objectives of today's discussion? We'll discuss the new diagnostic criteria of acute kidney injury in cirrhosis and apply this criteria in clinical practice, discuss the updated management approach to AKI, and review update in the management of hepatorenal syndrome. So, brief introduction. Renal dysfunction is a severe complication of advanced cirrhosis, as we know. The types of renal failure we get in clinical practice, that's pre-renal, renal, and post-renal. And specific type of renal dysfunction that's called hepatorenal syndrome. This is unique to the patient with advanced liver disease. So what is the news in pathophysiology, definition, and classification of hepatorenal syndrome? Because in the last 15 years, there are many changes in this field, and a step beyond the International Club of Ascites consensus document. What are those? So epidemiology, acute kidney injury is very common. According to the recent cohort studies, applying the recent criteria of AKI, the incidence of renal failure in hospitalized patients is 27% to 53% in cirrhotic patients. Out of those, 10 to 30%, and on an average, 20% of the patients develop HRS. Prevalence of HRS AKI is very common in cirrhotics who develop SPB or any other infections, that is 30%. In severe alcoholic hepatitis, it's very common, 25%, and serial large volume paracentesis, the incidence is 10%. So, what are the types of AKI? The types of renal injury in cirrhotic patients, most common is pre-renal, that is 70%. Second is intrarenal, 29%. And post-renal is very rare. It's, for example, bilateral ureteric stone obstructive uropathy. So it's very rare. So coming to the most common, that is pre-renal acute kidney injury. Out of these pre-renal, most of the patients are volume responsive, that is 66%. And the most common precipitants is sepsis, GI hemorrhage, diarrhea, overuse of diuretics, non-steroidal anti-inflammatory drugs use, and iodinated contrast dye use. The out of these 70%, 34% are volume non-responsive. These patients develop hepatorenal syndrome. Now, according to the old definition, this is hepatorenal syndrome type 1, 25%, and HRS type 2, 9%. That is the old definition. Now, what are the pathophysiology? As we know, that in cirrhosis, there is increased stiffness of the liver leading to portal hypertension. The main pathophysiological mechanism is splanchnic vasodilatation. There are many components. So, as soon as there is splanchnic vasodilatation, there is low effective arterial volume, leading to activation of renin-angiotensin-aldosterone system, leading to sympathetic overactivity and leading to ADH release. Apart from this, new concept in the recent years has come that whenever there is any insult to the liver, there is apoptosis or cell death of the liver cells, release of disease associated molecular patterns from the liver that activate cytokines. Apart from that, that cirrhotic stage is the increased gut permeable state, and due to translocation of the bacteria, there is a release of pathogen associated molecular patterns. These both factors, PAMPs and DAMPs, stimulate stellate cells and other immune system, and release of there is cytokines, and these cytokines further aggravate splanchnic vasodilatation. Apart from that, in later stage of cirrhosis, there is development of cirrhotic cardiomyopathy, and patients are usually less responsive to hypovolemia and develops cardiac myopathy. So then again aggravate the splanchnic vasodilatation. All these components leads to decreased sodium excretion and sodium retention, increased water reabsorption, and increased renal vasoconstriction, leading to decreased GFR and ultimately leads to hepatorenal syndrome. So what's new in pathophysiology? The recent years, the pathophysiology, as I told, the spams and dams concepts come from the increased translocation of bacteria or any infection or any type of liver insult, even in the absence of infection. Suppose there is an acute alcohol intake, there is a death of liver cells, release of PAMPs, that is pathogen associated, or DAMPs, particularly in DAMPs, even in absence of infection, that leads to further activation of immune system, leads to aggravation of vasodilatation, leading to hepatorenal syndrome. So HRS pathogenesis is complex. That's due to renal hypoperfusion, dangerous signals, that is DAMPs and PAMPs, microvascular dysfunction, and recent concept, that is bile salt mediated. In patient, a jaundice patient with high bilirubin, there is direct damage to the bilirubin, direct damage to the tubular cells, leading to further aggravation of renal vasoconstriction. So diagnosis. So what is the new definition of acute kidney injury? In 2010, acute kidney injury redefined as increase in serum creatinine to 0.3 milligram per dl within 48 hours, or a percentage increase in serum creatinine 50% from the baseline, what is known or presumed to have occurred within the prior 7 days. What is different from the previous definition? The previous definition, there were fixed criteria of creatinine, that is 1.5. As you know, in cirrhotic patients, creatinine is hampered by many factors because of the less production of creatinine from the liver. Second, because the hemodilution state, there's a false low elevation of creatinine, and due to profound sarcopenia, the less creatinine production. So this creatinine fixed level was not reliable. So this has been changed. Any increase from the baseline from 0.3 milligram per dl or 50% from the baseline. What is baseline? This is very important. So serum creatinine obtained in the previous 3 months, if more than one value within the previous 3 months, the value closest to the admission time to hospital should be used. In the absence of a non-serum creatinine admission should be used as baseline. So staging of AKI, stage 1, increase in serum creatinine level of 0.3 milligram per dl or more than 1.5 fold or equal to 1.5 fold to 2-fold above baseline. Stage 2, serum creatinine level of more than 2-fold to 3-fold above baseline. Stage 3, serum creatinine level of more than 3-fold above baseline or serum creatinine level of 4 milligram per dl or initiation of renal replacement therapy. Most of our patient falls in stage 1. Most of the admitted patients, 69%. Rest of 19 and 13% respectively to stage 2, stage 3. Most of the stage 1 patient managed easily with the volume replacement and correction of dehydration. Stage 1, few patients, and most of the stage 2 patient went into hepatorenal syndrome. In 2015, HRS criteria was revised. And what are the Roche diagnostic criteria? Cirrhosis, acute liver failure, or any form of advanced ACLF. Increase in serum creatinine equal to or more than 0.3 milligram per dl within 48 hours or more than 50% from the baseline value according to ICA, International Ascites Club of Ascites consensus document. And or new thing was added, urine output decrease equal or more than 0.5 ml per kg body weight more than 6 hours. So what is new in this definition? In the previous HRS criteria, the definition fixed a rise in serum creatinine, rapid rise within a period of 2 weeks to equal or more than 2.5. That was the fixed criteria. The fallacies of that fixed rate creatinine was removed because, as I told, that in cirrhotics, this creatinine value varies in cirrhotic patients. So this has been changed. This was the major change. No fall or partial response according to ACA consensus document after at least 2 days of diuretic withdrawal and volume expansion with albumin. The recommended dose of albumin is 1 gram per kg body weight per day to a maximum of 100 gram per day. Absence of shock, no current or recent treatment with nephrotoxic drugs, absence of renal parenchymal disease as suggested by proteinuria more than 500 milligram per day, microhematuria suggested by more than 50 red blood cells per hyperfield, urinary injury biomarkers. This was the latest addition, but it's not approved. It's suggested if available, or abnormal renal ultrasound just to detect, just to exclude CKD. Suggestion of renal vasoconstriction with fractional excretion of sodium less than 0.2%, with levels less than 0.1% being highly predictive. So these two things was not added in the diagnostic criteria. The first is urinary injury biomarkers and this fractional expression of sodium. This is not validated in further studies, but it's applied. So what was the fallacy of this study? This criteria. If you look at the fourth point, no full or partial response after at least two doses of diuretic withdrawal or volume expansion with albumin. Suppose a patient of cirrhosis comes with volume overloaded state and just to fulfill the criteria will infuse 2 days albumin, that patient will go into the pulmonary edema. So that was the major fallacy. So acute disease quality initiative, International Club of Ascites and Kidbook, both the three societies came together and said, and they again revised in 2024 this criteria. With all the similar findings, one major change, that was the third point, absence of improvement in serum creatinine or urine output 12 to 24 hours following adequate volume resuscitation when indicated. If the patient is hypovolemic, if the patient is overloaded, don't mandatory to infuse albumin. And the second, they have changed the 2 days criteria. If your IVC is full, your CVP is normal within 24 for 12 to for 24 hours, then you fulfill the criteria of acute this HRS. So this changes uh, helps in early diagnosis of hepatorenal syndrome. So HRS subtypes again redefined. Old classification HRS1 is redefined as HRS acute kidney injury. So all the criteria of AKI, like absolute increase in serum creatinine more than 0.3 milligram per dl within 48 hours, or urinary output less than 0.5 ml per kg for more than 6 hours, or percent increase in serum creatinine more than 50% using the last available value of outpatient creatinine within 3 months at baseline. So this is the new definition of HRS AKI. This HRS1 has changed to HRS AKI. Now, HRS2 was a very vague definition in the old criteria. So this has been changed to HRS non-AKI and again categorized into two groups, HRS acute kidney disease, HRS CKD. Now the criteria for to diagnose HRS AKD, if there is decrease in EGFR less than 60 ml per minute per 1.73 meter square for less than 3 months in the absence of other structural disease. Second point, percentage increase in serum creatinine less than 50% using the last available value of outpatient serum creatinine within 3 months of the baseline means the patient who does not fulfill the criteria of HRS AKI falls into HRS AKD, but less than 3 month duration. This is very important. If the persistent rise in creatinine or decrease in EGFR less than 60 ml per minute for 1.73 meter square for more than or equal to 3 months, in the absence of other, this classifies HRS CKD. So what's new in diagnostic criteria? Just to summarize, new diagnostic criteria by Angeli et al., most of the studies by Angeli et al., changed the nomenclature from HRS1 to HRS AKI and then HRS2 to HRS non-AKI. It included other etiology apart from cirrhosis like acute and chronic liver failure, acute liver failure, included urine output as a criteria for assessment of critically ill patient, and urine biomarkers have been suggested but not validated and not approved by FDA. Volume expansion only when indicated. This was the major change. HRS2 is poorly defined in the previous definition, assumed more chronic abnormalities without a definite timeline. Sanjali et al. Proposed that diagnosis of HRS non-AKI can be made in the context of CKD, that is GFR less than 60 ml per minute, for more than 3 months, as I told, in whom other causes have been excluded, or in the context of acute kidney disease defined as renal dysfunction that does not meet the criteria for AKI and lasts for less than 3 months. This is HRS, acute kidney disease. So what would be the approach to management of acute kidney injury in CLD patient? So in cirrhotic patient with ascites, the most common causes of acute renal failure is differential diagnosis of pre-renal, acute tubular necrosis, or HRS. Pre-renal is mostly 37%, acute tubular necrosis 42%, and HRS is 20%. So if you see that according to the latest definition, pre-renal 68, non-volume responsive 34%, this falls into HRS AKI 25% majority and HRS non-AKI 9% and volume responsive 66%. So it's very important to differentiate before going to manage HRS uh, between HRS and acute tubular necrosis. So what are the point in favor of HRS and ATN? So recent history of shock, it's more favor of ATN. Likely to volume change, not very much helpful. Urinary excretion of sodium if less than 20, more in favor of HRS. Urinary excretion of sodium more than 40, more in favor of ATN. Fractional excretion of sodium, this is very important, but not validated the exact level, but less than 1 is more in favor of HRS, more than 1, more in favor of ATN. Urine osmolarity, less than 500, favor of HRS, more than 350, favor of ATN. Granular cast suggest ATN. So this is very important because if you choose the therapy of choice, HRS is entirely different disease and ATN is different. In ATN management is completely supportive. And if a patient develops ATN and you give vasoconstrictor therapy, because those vasoconstrictor drugs like terlipressin are not at all safe. So very important to differentiate HRS and ATN. So role of urinary biomarkers in recent studies, this has been many studies, but only challenging. There are many studies that NGAL is the one factor, the most extensively studied, and this is promising in the coming years. Interleukin 18, one albumin. These are the three significant values come in studies. But most promising are urinary biomarkers are NGAL, that is urinary neutrophil gelatinase associated lipocalin. Very simple to assess, but it's costly, not readily available. Interleukin 18, albumin. These values significantly higher in patients with ATN than in those without ATN. So NGAL is a marker of renal injury. NGAL has been most investigated biomarker consistent in differentiating functional from structural acute kidney injury. Cutoff is suggested 220 microgram per gram, but not yet validated, not available. No difference in anger level in treatment responders and non-treatment treatment responders. That is the disadvantage. So coming to the management of HRS, mainstay of management is medical therapy and liver transplantation. Since most of the our states liver transplantation is not available and liver not easy, so in our hand remains the medical therapy. The role of TIPS is latest recommendation, not for the management of HRS, extracorporeal support system, it's not only for experimental purpose. So going in the details of the medical therapy. So while you just managing, you just try to categorize your patient, which stage falls in your patient. Stage 1 AKI, stage 2, 3 AKI. Stage 1 AKI, that most of the patient falls, close monitoring, remove risk factors, plasma volume expansion. In case of hypovolemia, if there is a resolution, good, close follow-up, stable follow-up, and progression, then you just withdrawal of diuretics and volume expansion with albumin if indicated. If there is a response, yes. If there is no response, means if your patient meets criteria of HRS, then you categorize and choose your therapy, that is vasoconstrictor albumin. If the patient has already developed ATN, it's mainly supportive. So medical therapy for HRS, the most validated and most studied is the combination of IV albumin and vasoconstrictor, that is terlipressin. So IV albumin, the dose recommended is bolus 1 gram per kg per day on presentation, maximum 100 gram per day daily. Continue 20 to 60 gram daily as required. Target maintain CBP 10 to 15 centimeter of water, and nowadays we use bedside ultrasound just to monitor IBC fullness or IBC variability. In our hospital, this most common tool nowadays we manage this patient, but sometimes very difficult to do if the patient is having tense ascites. In that case, CBP is also very helpful. Most of the studies have suggested CBP measurement. Role of albumin is very important. It maintains cardiac output. It improves effective circulatory volume. It improves cardiac contractility. So, if cardiac output decreases, terlipressin worsens systemic vasoconstriction. So that is the rationale for combining albumin with terlipressin. So vasoconstrictor in addition to albumin, terlipressin. What is the dose of terlipressin? Most of the studies, IV bolus to start with 1 milligram 6 hourly for 48 to 72 hours. So maximum of 2 milligram 6 hourly for additional 4 days if response treatment maintained up to 14 days. Start with 1 milligram 6 hourly, wait for 2 to 3 days. If there's a response, how do you assess response? There's decrease in serum creatinine 20 to 30% from the baseline after 2 days. If not, increase the dose to 2 milligram 6 hourly for additional 4 days. If response continue to 14 days, Another mode of giving terlipressin in a recent study published in 2016 in Hepatology, that continuous IV infusion of terlipressin. This is a very safe and the dose requirement is less. In our hospital, we practice this mode of therapy, 2 milligram per day for 48 hours, increase every 48 hours if no response to maximum 12 milligram per day in continuous infusion form. So what is the definition of responders, non-responders? So responders treatment stopped when serum creatinine reaches a value of less than 0.3 milligram per dl of the baseline value before starting therapy. Non-responders treatment stopped after 2 to 4 days of achieving the maximum tolerated dose, and this represent a maximum of 7 days if bolus administration is used or 12 days if continuous infusion is achieved. Treatment should be stopped if patient develops severe adverse event. The most of the minor adverse effects are persistent diarrhea, abdominal ischemia, peripheral ischemia, respiratory failure, angina pectoris, and circulatory overload. The most dreaded complication we have encountered in clinical practice is cardiac events. The patients may develop bradyarrhythmias and sudden death. One of the patients I have seen in Vedanta in front of me, bolus given and patient sudden onset develop a bradyarrhythmia, elderly patient, and patient died. So in this particular, how to avoid these symptoms? In the most of the trials, it has been seen that if the patient has baseline oxygenation problem, means patient has respiratory problem, or patient has having fluid overloaded, avoid terlipressin because the most patient land up with pulmonary edema. So just look for the baseline oxygenation and any respiratory problem. And if the patient is having pre-existing cardiac disease, avoid this drug. The most of the studies in 2000, starting from 2000, that's Arun Sanyal group with terlipressin as all the studies from America. In the initial study is 2008. It has just shown that the patient with terlipressin who received terlipressin and albumin, and the patient who received albumin and placebo, the response rate in the terlipressin group was higher. In the Arun Sanyal group reverse studies, then again show the similar results and then pull the data and analyze the shown similar results. But FDA rejected each time these drugs because this was not very safe. This is the landmark trial published in NEGM in 2021 from North America. So in this same study, terlipressin plus albumin for the treatment of type 1 hepatorenal syndrome, in this study they took 300 odd patients. This was the phase 3 randomized trial. 199 patients with type A hepatorenal syndrome were assigned to receive the vasoconstrictor terlipressin plus albumin, and 101 to receive placebo plus albumin. The renal function was better than terlipressin than with placebo. However, mortality was not lower, but terlipressin was associated with adverse events, including respiratory failure. In the study, the interesting finding was that 12% in comparison to the placebo, 12% died because of the respiratory problem. So again, FDA rejected this drug. Then they analyzed later on in 2022, and what they red box warning they have given, and approval came in 2022 by the FDA. This is the only drug approved for the management of HRS. And this study they have shown that the patients who presented with respiratory problem, the patient with grade 3 ACLF, and patients with volume overloaded, the respiratory complications were more, and those patients were died. The red box warning was that if the patient has baseline oxygenation is less, patient has a ACLF grade 3, and patients with volume overload, avoid this drug. And with this caution, this drug was approved by FDA in 2022. So if you see, there is a HRS reversal maintained at 180 days survival better, but no difference in the overall mortality rate in patients. So what are the predictor of response in terlipressin? Lower MELD score, lower serum creatinine, lower total bilirubin, absence of alcoholic hepatitis, normal baseline oxygenation, lower grade of ACLF, lower MAP, absence of precipitating factors for HRS at baseline, or male sex. So this is the study in hepatology, with terlipressin given by continuous intravenous infusion versus intravenous boluses in the treatment of hepatorenal syndrome, a randomized controlled trial published in hepatology. So in study, terlipressin given by continuous IV infusion is better tolerated than IV boluses in the treatment of type 1 HRS, and it is effective if doses lower than those required for IV bolus administration. No cardiac events, adverse events noted in the study. So this is a very safe mode of administration of terlipressin. So later, people have tried terlipressin versus noradrenaline just to show the cost effectiveness. Many studies from India also. So noradrenaline is alpha adrenergic agonist, 0.5 to 3 milligram per hour given at continuous intravenous infusion. This drug is readily available. Aim of increasing mean arterial pressure by 10 mm mercury. Treatment is maintained until serum creatinine decreases to 1 to 1.2 milligram per dl. Norepinephrine 0.5 to 3 milligram per hour plus albumin was shown to be as effective as terlipressin in three randomized controlled trials, one from ILBS also, whereas a recent trial showed that terlipressin was more effective than norepinephrine in patients with HRS-AKI in ACL, same from the ILBS group. So the current conclusion is that most of these three studies are meta-analysis suggests that this is a small number, underpowered, unblinded study, no survivability. But only thing was the cost effective. But demerit is that whenever you start noradrenaline, you have to keep the patient in ICU with central pressure monitoring. So again, the cost effectiveness as per drug is good, but you have to keep the patient in ICU. Midodrine is a new drug, again tried for the management of HRS, not FDA approved. Alpha agonist 7.5 milligram TDS increases up to 12.5 milligram TDS if needed. Titrate to a mean increase of at least 15 milligram per mercury. Used in association with octreotide, 100 microgram subcutaneous thrice daily, increased up to 200 microgram thrice daily. So midodrine with octreotide can be used as an alternative in cases where terlipressin and noradrenaline not available. A multi-center RCT showed that midodrine octreotide are significantly less effective than terlipressin. No major adverse event compared to terlipressin in multiple small studies. But where the terlipressin is not available, patient is not affordable to terlipressin because the cost of octreotide is less and only 3 doses you required daily. And even you can give subcutaneously in the general, what I've tried in few patients, but sometimes it's effective. So midodrine with octreotide can be used as an alternative in cases where terlipressin and NORAD not available. Efficacy and survival were lower compared to terlipressin. Larger acid is needed to establish exact effectiveness. No major adverse event compared to terlipressin in multiple small studies. Role of tips, considering the short-term effect of vasoactive drugs, tips may help to increase survival in selected transplant uh, not eligible candidates or waiting list where it improves renal parameters. In all the studies with tips with HRS, old definition that was refractory ascites with HRS2. So it's helpful in the management of refractory ascites, but not for the reversal of HRS2. So latest guideline, EGL guidelines 2018 tips is contraindicated in HRS-AKI. Severe liver dysfunction because those patients with HRS usually severe liver dysfunction, tips precipitate hepatic encephalopathy, so it's contraindicated. Although it's helpful in refractory ascites, better large acid is needed to recommend its use currently in HRS. So this is of the group of patient you directly start on Lasix infusion. So this is the patient where Lasix infusion works dramatically. And simultaneously you assess the CVP pressure. If CVP pressure allows, you can give the patient is hypoalbuminic, you can transfuse albumin slowly. So albumin plus Lasix infusion, albumin very cautious. If the patient CVP is very high, chest is bad, don't give albumin because further patient went to respiratory failure. So if the patient within 48 hours, you 24 to 48, the Lasix responsive. If the patient is urine output improves, most of the patient improves with Lasix infusion. If doesn't, then ultimately at last you subject to dialysis because once you subject this patient to hemodialysis, the outcome is very bad. Usually do not tolerate dialysis. Small means CRRT can tolerate. CRRT is not readily available in our setup. So if CRRT is available, if dialysis is required, CRRT is the choice of dialysis. Don't tolerate, yes. Yes. Yes.
Dr. Pranav,
Hmm.
how do you manage the HRS CKD who cannot afford liver transplantation? That's the main challenge.
So, yeah, this is the patients usually very difficult. That's Sangeet just told, the subset of patient, ultimately few group of patient that doesn't respond to diuretics ultimately lead to dialysis. Usually poor outcomes, sir. So renal replacement therapy is the only modality helps, and there is no other modality except liver. And even if liver transplant, you subject this patient to liver transplant, post-transplant outcome is very bad, and this is the group of patient requires simultaneous liver kidney transplantation. Sir, we usually do not specifically use for the renal admitted patient hospital. The renal means use with combination of this drug, but in midodrine patient with refractory ascites, midodrine works very good with some kind of renal AKI. Usually improves what I have shown, but not studied extensively what is the outcome. But usually in OPD practice, we use very frequently midodrine. If the patient is not responsive to diuretics alone.
Hypertensive also.
No scientific evidence.
And then they are hypertensive also. No? So many times they are hypertensive also. Giving midodrine is also.
Yes, not validated. It's large, requires large RCTs for that. But very frequently, you told rightly. Even in higher center, our ILBS prescription, they are prescribing midodrine, and up to 12.5 milligram they are prescribing. Yes. 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 Yes.
Very nice, a comprehensive review, Dr. Mandal.
Yes.
So one thing I just wanted to add that in the volume status of the patient assessing IVC is also very, very important.
That I told. In our center, we are doing IVC.
Point of
IVC.
ultrasound. I mean, most of us know how to do ultrasound. So our
Yes.
social care specialist.
Yes, yes. Most of the center in Ranchi, they are assessing with
Care ultrasound, and this should be practiced more and more often to assess the volume. The second thing what I wish to highlight is the difference between HRS in patients of ACLF and patients of established cirrhosis. So HRS in these two subsets behave differently.
yes.
So what has been your experience in managing, which is the most difficult subset to manage HRS in patients of
HRS with ACLF. This is the most subset difficult because those patients are having organ failure also.
and
So
what's my experience has been the traditional thinking of managing HRS and ECLF does not always work.
yes.
One has to use combinations, may not wait for the same treatment to have the effect. Change over treatment is say, as you rightly mentioned about Lasix and Pevin, we should be not be waiting for 24 to 48 hours,
Yes.
which we usually do for Lasix and Pevin. In ACLF, if you do not see a response in 8 to 12 hours, we will shift to other modes of therapy.
Yes. But ACLF, you must see the patient's which grade of ACLF. If the patient is having respiratory failure, you can't use terlipressin because all the studies high mortality with in ACLF group also.
Other than a little bit of NORAD and albumin,
yes. Yes. Triple combination, I meant to say. Yes, people are using many things, but they're not recommended. Not recommended. Case by case, you can, sir is telling that midodrine everybody is writing, but there is no evidence. Not resolving AKI, there is no role. Studies are, very few studies are there with comparison with terlipressin, midodrine plus octreotide, not better. Terlipressin works, but alone midodrine plus other combination not superior than terlipressin. So it's a failure. Treatment not responders.
Usually, hyponatremia is the additional problem in these patients.
Yes.
And there is no need to correct hyponatremia. Very little which we can do more. And diarrhea with terlipressin is
very common. Diarrhea.
Diarrhea. Then what?
First, you stop your all laxatives. Try to manage it, but if it is intractable, then only you stop. Okay.
Thank you, sir, for a most illustrative talk on HRS AKI. So we are moving to our next talk. So we have Dr. Rakesh sir from Bokaro. He has taken deep pain from coming from Bokaro in early morning hours from Muskan Hospital. I request sir to please give insight on some of very few interesting and practical cases being encountered in our day-to-day clinical practice. Shall be waiting for sir. Laptop Good afternoon, everyone. And before I start, I must thank Dr. Manohar and Dr. Chandan for this invitation. Today, my topic is the art of medicine is relevant in gastroenterology. So, in the era of technological advancement, sometimes we feel the medicine has lost its touch. The art of medicine has lost its touch, but it is as relevant even today as it was in earlier times. And the art of medicine is nothing but we have to get the facts from the patient's history, the recent advances, technology, investigations,
कहाँ से cancel होगा? And solve the puzzle which is presented to us in a case of a clinical problem. It could be very simple thing. Just like this puzzle, you have to find out which is the missing piece here. And oh, नीचे चला जा रहा है. हो गया.
Yes, हो जाएगा. Missing है.
हाँ, इसको कॉपी कर देना है.
सर ऐसे नहीं है, कोई नहीं है.
यहाँ पे कंट्रोल.
ये पूरा कॉपी कर लेना.
हाँ, कॉपी कर देना. Just है ही नहीं ऑप्शन. कंट्रोल भी.
फिर उसको अंदर से अंदर खोलिए ना. एक साइड पर इसको कॉपी क्लिक है.
नहीं कर रहा है.
ये कॉपी हो जाएगा. पेन ड्राइव स्कैप कर दो. इसको स्कैप करना पड़ेगा.
नहीं, वो वैसे ही बताएगा.
प्रिंटिंग वाला बता दो.
आ गया. अब इसको निकाल लेते हैं तब. तो फिर ये
वो आते हैं.
अब नहीं आएगा वो.
नहीं.
So when a patient present to us, we have to utilize all the resources at our command, and that is the art of medicine. It could be history, it could be investigation, it could be the new technology, newer investigations, molecular medicines, and all these combined lead us to the solution of the problem. This is like a word puzzle. You don't know which word is missing, but if you have a good knowledge base and if you can fill in the blanks, it could be as simple as this one. So, and these pieces are history, investigations, other observations. So, what I am going to present to you is a case. I had never seen this patient in person, but it was all on telephone basis. This patient is a 46-year-old woman who was advised liver transplantation. She also happened to be the wife of my close friend in ISC. So he asked me what to do now, from where to get the donor and all those things and logistics involved. And he himself was having some chronic liver disease, so he was a little bit scared who will be donating the liver. When I asked about the details came out as she has been a diabetic for 11 years. She had chronic diarrhea. Since the times he knew her, she was having diarrhea, and she was also evaluated in Delhi, was advised GFD for few months, but there was not much relief and it was discontinued. This was her problems before developing some problems of late. In the last 2 years, what had happened? She had started developing episodes of unconsciousness. These episodes were quite frequent, sometimes even occurring 3 to 4 times a month. And she would improve with the usual hepatic coma measures. Incidentally, one of her close relative was a gastroenterologist himself. So at times she would be treated at home also. And she would respond. At times she would require hospitalization. And many a times her ammonia was high. But recently, when this came, case came to me about 3-4 months back. While having such episode, she also developed complex partial seizures. And then she was evaluated by a neurologist friend of the gastroenterologist who did everything possible, CSF examination, MRI, and all those things. And what came out was some white matter changes in the MRI. CSF was evaluated for all the things. And again, she improved with the treatment that she received, lactulose, rifagat, and all those things. And the neurologist advised that you better go to NIMHANS, get an opinion, and get evaluated further because there was some atypical features in her presentation. So this patient went to Bangalore. That was also her parents' home. She was evaluated at NIMHANS. While undergoing evaluation, she again developed encephalopathy, episodes of encephalopathy, unconsciousness, was admitted in NIMHANS. And what happened that after initial evaluation, they found that they could not do much in this case. And this patient was referred to Sakra Hospital under gastroenterologist care, where she underwent usual treatment, all investigations, and a session of hemodialysis, she improved. Then at Sakra, they did liver biopsy. Of course, all basic investigations had already been done before many times. There was no etiological cause known in her case, except she was having some fatty liver. So, liver biopsy showed advanced fibrosis. It was not cirrhotic, but it was advanced fibrosis and some NASH changes. And then this was advised because of these frequent episodes that she should undergo liver transplantation. Because of the liver transplantation issue, they consulted another doctor, which was in Manipal Hospital. He suggested that let us go for CT angiography. We will look for portosystemic shunts. In case it is there, then we can obliterate it, and maybe that is the cause of encephalopathy. So CT angiogram was done, which was also normal. Then this liver biopsy was sent to CMCH, or maybe the patient also went. I'm not that sure. And what happened? The report came from there, advanced fibrosis and NASH. And ultimately, the consensus was that she should go for liver transplantation. Examination had shown that she was a little short stature. She had hepatosplenomegaly. Because of this short stature chronic diarrhea, she was suspected to have celiac disease, was evaluated at GB Pant Hospital, was advised GFD, but didn't work. She also had little bit of pancytopenia, not very severe, but everything was on the lower side. She was anemic, leukopenic, as well as low platelets. LFT were mildly elevated. SGPT in the range varying from 50-70, between 50-70. Low albumin, low protein. Her liver was like any ultrasound report, coarse, fatty. There was no evidence of portal hypertension or ascites, at least radiologically. And upper GI had no varices. During encephalopathy, increased serum ammonia whenever was done, was scenario, which this patient comes to her husband asked me whether to get the transplant. Is there any other option? What should we do? So let it be active session. I have presented to you the case as it was facts given to me. Can you suggest what should be further invest? Any idea? Yeah, autoimmune, ceruloplasmin, viral marker, all the ferritin, all those things. I'm not sure people per se, but a deep biopsy was done. That was done from the area point of view. Yes, I can. So, very rightly pointed out. What is odd in this? However, I've already was a patient malabsorption, childhood short stay, diabetes, metabolic for last 2 years. Now hepatospleen, hyperammonemia 199, normal blood urea, hypertriglyceridemia, plasma lactate. He was hyper bilateral. These are the points based on which advised transplantation. At frequent regimen, hyperammonemia, hepatospleen, biopsy. That was the odd way. She was evaluated for PH shunts, portosystemic shunt. It was not there. So, what other diagnosis can explain her condition? Is it really liver related, and should we subject this patient to transplant, even if it's urea cycle defect? Liver transplant may solve the issue, or should we all further investigate? That's the question. Like, there's one good suggestion that urea cycle defect, urea cycle defect, you can also treat by transplant. Suppose the diagnosis was not made and she had undergone transplant, the UCD would be treated. Of course, not as a first choice. You have other modalities to treat, but in case it is done, it will be cured. So, what do you think? Should this patient proceed with transplant or should be further investigated?
Transplant is not done anymore.
Why?
I mean, the classical things of decompensation are not there at all.
So, how do we treat these frequent episodes, which means occurring every
we have to look
3, 4, 5 times in a month?
encephalopathy is not always shunt related. There can be other causes of hyperammonemia, and gut has to be investigated because I feel the gut is the cause over here, and we are ignoring her white matter changes.
So what is there in your mind?
It's difficult to say at the moment. Some kind of a malabsorption is there.
So what I am presenting here is these are the issues where the art of medicine comes. You have to keep thinking. You have to broaden your horizon, and you have to think outside gastroenterology at times. Everybody is online. I think everybody is thinking that transplant right now should not be done. So this is what I also thought. And of course, possible causes were like this, all almost ruled out: liver, kidney, PS shunts, hypoglycemia, hyperglycemia, drugs. What was left was inborn errors of metabolism. So now the question comes, which inborn error of metabolism has hyperammonemia? First step. So we know UCD, rightly suggested, fatty acid oxidation defect, and organic acid disorders. Problem is, most of these disorders would present in the early childhood, infancy, sometimes in neonates. Of course, some of these disorders do present late if they are of the milder form, or patient is heterozygous, or there is some X-linked carrier where it may happen in UCD also. Yeah. Yes, yes. Yes, right. Citrullinemia may come in adults, even OTC also. X-linked may come in adults if it is a heterozygous carrier only. And FOODs also, some of these may present late, but many of these conditions would present early. But she had some features which suggest that the onset may be in the childhood because she was short stature. She had hepatosplenomegaly. Organic acid disorders we would rule out at this juncture because she had undergone ABG many times. There was never metabolic acidosis. So this is the first. Everybody is concentrating on urea cycle disorders. We know what is the urea cycle disorders, and as pointed out, this CPS1 is the main rate limiting enzyme here. So I will just summarize it. When you have such symptoms, plasma amino acid, you do analysis. And if you have high arginine, low arginine, based on that, you decide. Usually in urea cycle defect, you will have low arginine, except in arginase deficiency. And then based on whether arginosuccinate on whichever is high, you decide which enzyme would be defective and which could be the defect here in this, and whether it is urea cycle defect or not. But most of the time what happens, if you do plasma amino acid analysis in urea cycle defect, what happens? The arginine will be decreased, citrulline will be decreased, and ornithine will be increased, lysine will be increased, and arginine is increased, as I told you, in arginase. This patient, we went for plasma amino acid. That time plasma amino acid was not readily available, so I had to send this sample. It was picked up from Bangalore, went to Hyderabad, got tested over there. And what you find here, interestingly, you just see the 32, 33, 34. Ornithine is low. It should have been high, urea cycle disorder. Lysine is low. Arginine is low. Three things are low. And what you see above, glutamic acid is high, alanine is high. Why glutamic? So here you are seeing a different, what is usually found in urea cycle defect is not there. Here you are seeing lower ornithine, lysine and arginine, and higher glutamine, alanine. What does it point out? Urea cycle defect is not there, but there is a problem in the urea cycle. Yes. So there is something problematic here. When we do a plasma amino acid, we should also do urine amino acid at the same time to see what is happening in the urine. If the plasma level is low and urine level is high, then you know there is something in the kidney. So we have to correlate. And you just see here again, ornithine, lysine, arginine. Ornithine is high, arginine is high, lysine is normal. So this shows, and this alanine and glycine, all those are high because of the higher plasma levels, it is getting excreted out. So there is corresponding decrease in the plasma, and there is high urine excretion of these materials. That shows that the fault lies here in these three amino acids. And this was the suspected diagnosis. When you see urea cycle defect, you also have to look for causes which resembles urea cycle. And lysiniuric protein intolerance is one. This was our clinical suspicion with which we had sent the sample. And lysiniuric protein intolerance, you have three dibasic amino acids which are not absorbed. As sir was pointing out in the GIT, it is not getting absorbed because these transporters are defective, which are there in the GI and the kidney. So it is not getting absorbed, plasma level is low, and whatever is there is getting excreted because it is not getting absorbed in the renal tubules also. So all these are being excreted out. So urine level is very high. And this was compatible with lysiniuric protein intolerance. But you have to prove it. We also did urine amino acid. This is the chromatogram. Then we also did urine organic acids. What happens to urine organic acids? And why do we want to see this? Because if it was a fatty acid oxidation defect, this was ruled out primarily because of two factors. Fatty acid oxidation with hyperammonemia will have hypoglycemia, hypoketotic, and also this patient had undergone, they had something of that nature they had suspected in NIMHANS, and acyl carnitine profile was done, which was more or less normal. So that was ruled out, but still we wanted to do urine organic acid. Whether it shows high dicarboxylic acid, then it will suggest that there is some fatty acid oxidation defect. or orotic aciduria should be there in these urea cycle defects, especially in proximal defects or in lysogenic protein intolerance. But in this case, we didn't find any. It was all normal. There is a control above, patients above, and the control below. It was all normal. Orotic acid should have been high, but it was not there. Reason being, by then patient had already been treated. She was already on restricted diet. She had improved. So these metabolites had decreased, and therefore we could not find this. But still, it does not prove. To prove what do you need to do? You have to show those defects. In enzyme, we do fibroblast culture, but this is not available easily. At that time, what we could do was the whole exome sequencing. That was not available in India at that time. So I corresponded with somebody in the Germany, in German university. We got the sample picked up. It cost patients a lot. I had already told him whether he was willing to spend 1.5 lakhs or so. In case it is futile, then he will have to undergo transplant again after spending. But he was willing because he was my friend. So we did trio analysis, parents, both parents, and the proband. And this is the analysis. The defect was found in SLC7A7 gene, which is the gene responsible for lysogenic protein intolerance. And here we found this cytosine to guanosine, glycine uh, replacement, which was causing tyrosine stop codon. And tyrosine here, the protein sequencing was getting stopped because of the stop codon and tyrosine residue, and the protein was defective, which was causing this lysonuric protein intolerance in this case. And it was then matched with the database and was found to be likely pathogenic class 2. Class 1 is the highest grade of pathogenicity. Class 2 is the next, which is accepted as the cause for accepted as a genetic cause for the disease. And ultimately, this patient was diagnosed as lysonuric protein intolerance. Then we started treating this patient with simple measures. Sodium benzoate available in every store. Then restricting the protein. Patient herself was restricting her protein intake at times because of the aversion, and also we started restricting her protein and giving her enough calcium, vitamin D supplementation because the bone is one affected organ, and supplementing with citrulline. Because citrulline is one thing, because ornithine is not being absorbed, citrulline is not getting formed, and thereby urea cycle is getting affected. So we are giving the raw material to the urea cycle, citrulline. If you see here, you will come to realize how it works. Because ornithine is not there, carbamyl phosphate and ornithine will mix and citrulline become. Then citrulline will combine with aspartate and this. So we are giving citrulline to replenish the store so that the urea could form. Whatever is there, it would work. So citrulline supplementation we started, but patient was not tolerating very well this citrulline. But benzoate she was tolerating, and she remained free of hepatic encephalopathy. However, after about 4 years, she developed another complication, which is another story. But and this 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 was this I presented in the rare disease conference in Moscow. This was accepted for presentation, and I have omitted the name of the gastroenterologist whose name I had given because this patient was related to that gastroenterologist who is in Patna. So this is the case, and this is how you don't have to stop thinking, and you have to keep pursuing the investigation till you find the cause. If you had done liver transplantation in this patient would not have benefited from transplant. If it was a UCD, she would definitely would have benefited. She would have responded to those measures also, but at least transplant would have also benefited her. But if it was lysonuric protein intolerance, had undergone transplant after spending 25 lakhs and a donor, she would have still suffered from the disease because the problem in lysonuric protein intolerance is in the transporter. which transport these dibasic amino acids from the intestine and the proximal tubule. So that would not be taken care of. So even if replacing the liver would not have solved the issue, and she would have continued to suffer the same way. That is why uh, this is important to diagnose. Though it's rare, in India we have not had any report of adult lysinuric protein intolerance, and overall in the world I think 40 or 46 cases have been reported. In children it has been reported even in India also. So this is one interesting case I wanted to show you. And there are two almost parallel story, very recent ones. I have just presented my prescription as such. This patient came to me for evaluation of anemia, which she had been having for last 4 years. What you are seeing here is after taking all those leading questions and all those, thereafter some summary of the complaints. But otherwise, she had come to me for anemia because she had been anemic for 4 years and had been transfused 2 units blood in February only, a month before. Her problem was that for anemia, she was extensively evaluated, and the probable diagnosis made was myelodysplastic. She had also unsatisfactory stool for 1 month, decreased appetite, vomiting, postprandial weakness, fatigue. She was not able to walk or even climb to her one-storied building, and she had been an hypothyroid for almost 15 years on 25 microgram. So she practically came to me for this anemia evaluation because somebody told that now go and get a GI evaluation done. What is the cause for anemia? She had undergone bone marrow at Dhanbad, where there was non-specific finding. Then they went to some hospitals in Ranchi and then CMC Vellore. At CMC, she refused bone marrow. Again, with the probable diagnosis of MDS, she came back. But she was not improving. When I examined, she was pale. She had periorbital edema. And she recently had developed some restricted shoulder movement, kind of a frozen shoulder. Her spleen was palpable, 2-3 centimeter kind. I have omitted some of the points deliberately. And you see investigations, her investigation, iron is this, ferritin is 734 or something. Her TSH is 78.42, 4.55 T3, T4 TSH, which is on the lower side. TSH is also on the lower side. There were plenty of investigations, so I could not note down everything. Can you tell me how should I proceed in this case? What history should have been taken to reach a diagnosis? Because this patient gave clue only in the history itself. So if I reveal the history, straightway the answer would be clear. That is why I have omitted those points. And this history was taken on leading questions. It was not forthcoming. I had to ask those questions, and then automatically it came about. So what more would you like to know in history from this patient?
Urine color
Urine colors has been normal.
and intermittent intravascular hemolysis.
No, urine color has been normal. And recently she was, for her dyspnea and other symptoms, she was also seen by cardiologist. Evabred was started, and she was already taking iron supplement and many other medicines, calcium, all those things. Uh, uh, Type of anemia was normocytic, normochromic. No, like GI symptoms, I have already revealed whatever is there. I have not I have not hidden any GI symptoms from you. Whatever I could glean from the patients, I have told you. On asking, या कि पूछ ले, the main complaint was, डॉक्टर साहब मेरा तो खून ही नहीं बनता है, 4 साल से यही दिक्कत है, सब जगह दिखा लिए हैं, और she was scared of bone marrow because of the pain. No, no history of jaundice in the past. There's, other than she feels weak, she cannot walk few distance, she cannot climb stairs, she's anemic. So no fever, no chest symptoms, no weight loss. What sensitivity? No history of diarrhea. In fact, she is constipated. She says she has unsatisfactory stool. And that symptom is only for 1 month. She goes 2-3 times because she doesn't feel like that she has passed enough stool. So she would go 2-3 times a day. And her appetite is low. Her weight is quite good, 59 kg. Pulse is good. BP is okay. She was pale despite taking this, being transfused of 2 units of blood just a month before. Because she has been transfused, she has been taking iron. Sometimes even iron infusion was also given. Ah, like frozen shoulder was there. When I asked her, she said कि "हाँ, छोटा ये सब joint में pain रहता है." But that was very vague kind. When I asked about the swellings and all those things, some skin symptoms, it was not there. But yes, that was one of the findings that came across. Uh, that also differential came to my mind. Should I reveal the next point? I go to the next point. I come to the next patient. Then I will go to that patient again. Almost similar. That patient was 54-year-old, you see, and this is 35-year-old. This came in October. She came because she had lost 12 kg of weight in 6 years. She was having persistent nausea, vomiting. There was muscle weakness, fatigue, and she had one child, one abortion. She wanted to have another child, but the gynecologist said कि बहुत कमजोर हो, that is why you are not able to conceive. So, and she was referred to me by a gynecologist. I have omitted the name. On taking history, she was little anxious because she wanted one more child and she was not having it. And she was also quite weak. When I examined, she was lean and thin, 41 kg, mild paler, nothing much in the examination. And this is very interesting. And this has been going on for 6 years, and she has been seeing gynecologist mainly for her symptoms. In this case, the diagnosis was made. In the first case, that I had some differential. In this case, the diagnosis was made on day 1 because of one clue. And the credit goes to Dr. Seva Chakravarti, because during our internship days, she had given one such clue, which I remembered and which gave me the diagnosis instantly. So now I tell you the next thing about this patient. This patient is, I had revealed you the obstetric history. She is amenorrheic for 6 years. And for 6 years, she has not having these symptoms. I think I've got the diagnosis here. And see, this was postpartum amenorrhea. She had 1 unit of blood transfusion, postpartum, heavy bleed. This was all available in the history. Only thing was nobody was taking this history, so this was being missed. It is so classical. So that is why I say that in the puzzle, this simplicity, sometimes you find these things only by taking history. You don't have to add loss of axillary hairs, secondary sexual characters. Why? This is something which we were taught while I was doing internship. Dr. Subha madam called me once inside. We would never go inside we will always be outside making ANC cards. So once he called me, कि देखो एक अच्छा interesting case है. And she had also her PG around. That patient had also presented like this. थकावट होता है, ये होता है. Madam did nothing. She simply examined her axilla and asked the PG, what is the diagnosis? I want to give these clues because these clues might help you in future. क्या diagnosis है? She said, look, she has lost her axillary hair, secondary sexual character. This has happened after postpartum, she's feeling fatigue. This is because FSH, secondary sexual characters, is based on FSH. And she is not having is a Sehan syndrome. Take the history. And then she took the history afterwards. कि बच्चे के बाद खून भी चढ़ा था, and then she said yes, bleeding भी हुई थी. That was the kind of teaching that reminded me. And I also saw in this patient the axillary here. Normally I don't examine, but and there was loss of axillary here. So I made the Sehan syndrome diagnosis. I had deliberately not kept that diagnosis here. Here I will tell you, she was investigated fully. This is what was done: cortisol, ACTH, prolactin, everything was done, growth hormone. Also, from some academic point of view, though the diagnosis was quite clear: LH, FSH. And her, I tell you the relevant finding: she had mild hyponatremia, growth hormone was markedly low, prolactin was low, cortisol was low, ACTH was low, sodium was low, and her, surprisingly, her T3, T4, TSH was okay at that time. I got her MRI done. That was partial cellular, empty cellular tertiga. She was started on treatment. This is her MRI report, partially empty cellular, which was contrast enhanced in MRI, and there were some cystic things also. I started her on Visolone also because she was in this age group of 35. Estrogen and progesterones were also started. Initially, I started regularly for 30 days. Thereafter, she is now on cyclical estrogen and progesterone. And see her improvement in her hemoglobin was 8.6 or 9.6, I think. And see, after 1 month, her hemoglobin is 12.8. This was anemia of endocrine disorders. Because bone marrow is okay, but it is not responding because the hormones are not there. Without any supplementation, the things have started improving. What happened? In the follow-up, she became hypothyroid because her metabolism improved. Now the hypothyroidism manifested. So I had to start the thyronorm also gradually. Now she is on these medicines. This is her last follow-up, I think in the March or somewhere. And she has gained about 10 or 11 kg. I think the first weight was 40.3 and now she is 50 point something. Symptomatically better, no vomiting, nothing. Menstruation has not yet started. It may not start also because of for the long duration she has been without hormones. So that may lead to uterine atrophy, endometrial atrophy. But this is what we are giving her, hormone replacement. So we have to replace here thyroid, we have to replace cortisol, we have to replace estrogen, progesterone because of her age. Growth hormone is not necessary at this age. Now I come back to the previous patient, this 54-year-old. Somebody was saying lupus. Now see her obstetric history. She had two kids, live birth, and 5 abortions. This 5 abortions was something which made me think about lupus, because this is very common in lupus, but there could be some other causes as well. She is 54. She had tube ligation at 29 years of age, and the other findings I have kept it as such. Do you think that you need some more information in this patient from this history? You want to elicit something more? She's 54-year-old, hypothyroid for 15 years. I would like you to see the investigation carefully, because the clue is also coming from the investigation. And this has all been missed throughout 15 years. That's the spleen I was palpating, but I will come to you. In ultrasound, it was normal size, 11.3. So I could palpate it clinically. I don't know, maybe it was because of the. So if you are getting distracted by spleen, please don't be distracted. I got distracted by spleen while making the differential diagnosis because that time I had not done the ultrasound. So I also thought of some connective tissue disorders apart from the 3 differentials I had kept.
APLA can also cause this.
Phospholipid syndrome, lupus, yes. In yeah, agreed. But ferritin, I told you that she has been transfused and she has been getting iron also in plenty. So, but I will again tell you to look at the investigations more carefully, because this is the investigations she has been carrying, and many more such, even more, more, and these investigations really give you the clue. The next investigation, when I come to the investigation, it will be very obvious. I tell you, all these diagnosis is very simple, but if you miss one or two things, you will be off the track. And this patient has been for last 4 years been treated for anemia with MDS and all those things at various places, including CMC Vellore. Now I will give you the next information. Then I will come back to investigation, which I think I tell you the if I she underwent tube ligation 29 years ago and she's amenorrheic since then, but there is no history of postpartum hemorrhage. This is a new information to you. Because at 54 years, we are very reluctant. Sometimes we don't take menstrual history, but you should not miss taking this history. 54 years, you expect that the patient will be menopause. Why to take such history? But if you take history, then patient will give you. Otherwise, she is not going to volunteer out. She gave this history. I asked her when was her menopause? It was 29 years ago, when she was only 25. So it's a premature menopause. She had 5 abortions. So what you are getting, you are not getting any clue in the gastro symptoms. What clue you are getting is here, and also in the investigation, thyroid investigations. I'll tell you the normal range. T4 should be 80 to 200. This should be 5 to 15. T3 should be T4 80 to 200. This T4 should be around 5 to 15, and TSH you all know up to 5. Point 5 to 5 you can take it. So T3 is on the lower side, T4 is on the lower side, TSH is normal. And she is being kept on 25 microgram of, because every time the physician or the gynecologist or whosoever has seen, they have seen the TSH, they have not seen the T3, T4. And here you miss the point. Any primary hypothyroid, if a T3, T4 is low, her TSH will always be high. If TSH is low, along with T3, T4, it is not primary hypothyroid. And this was being missed because everybody would see TSH normal hai and continue with 25 microgram. Okay? And that was being missed, and also being missed because free T3, T4 was not being done. So you could miss here because of some little variation. But if somebody had done free T3, free T4, I think one would have picked up. But this was not done. And this was a great clue in this. Now you see the clue from investigation. I got the first clue from T3, T4, that she has central hypothyroidism. And the second clue from her amenorrhea, she has premature menopause. Again, premature menopause, central hypothyroidism means pituitary is at fault. I took the history of this postpartum hemorrhage, it was not there, which is the most common cause expected in, and she was anemic. Now, I had made this differential because I saw the spleen clinically. She had some joint pains and she had abortions, history of abortions. So I also thought of, as you said, antiphospholipid, APLA and lupus, because abortion is very common and multi-system disorders may present. And since bone marrow was done, MDS was kept as a diagnosis, I had still not ruled it out. So my differentials were 3: MDS, APLA, SLE, and the thing was this. And third was panhypopituitarism. That was my initial differential diagnosis. Then I had to narrow it down. Where is it going? I got this done for APLA, antiphospholipid antibodies, all normal, IgM, IgG, cardiolipin, antiphospholipid, all within normal. And also I did ANA was normal. I did serum immunofluorescence electrophoresis normal from other points of view, and her antiphospholipid evaluation lupus was also negative. Karyotyping I also did. She was perfectly normal, 46XX, because she had a history of abortion and all those things. So this was all normal. So she was now her hemoglobin is this 8.8. You are asking which type: 91.8, 29.6, 32.2, normocytic, normochromic. WBC is low, little bit. Platelet is more or less okay. So it's a normocytic, normochromic anemia, mild leukopenia. Now see free T3, free T4, and TSH. Now you see the difference. Her T4 is, free T4 is 0.4, 1.97, and TSH is still normal. That shows that the TS is not, the thyroid is at fault, the pituitary is at fault. Now this FSH, 1.79. She has menopause. Menopause means there is no estrogen production in the ovary. FSH should be very high. LS should be very high. No estrogen, no progesterone. Both are very low, FSH, LH. Her prolactin somehow was normal. There could be at times prolactin could be normal because the inhibitory stalk sometimes get stressed and there is no dopamine inhibition. So prolactin could be normal at times. So sir, FSH, LH is abnormal. Estradiol, progesterone, all in the lower side. DHES, because I wanted to evaluate adrenal, low, less than 15. Cortisol, 0.77. That was the reason for her not able to walk, having some vomiting. So again, ACTH 9.4. It should be around 20. It was a low. Human growth factor, hormone, low. Of course, I'm not going to replace it at this age, but IGF-1, low. So BMD was done to assess for her bone health, which was, of course, low. And this was the patient where MRI showed totally empty cella turcica. In the absence of Seahans, it could have many causes. Autoimmune hypophysitis is one, but the antibody which is assessed for that is not available in India. It's a kind of a research lab it's used. Then it could be some sarcoid, tubercular, anything may also lead to. So, but she had panhypopituitarism. We don't know the cause. And then she was, and this is the summary of her investigations, which I had told you that I had done serum IFE, ANA, dsDNA, NT-CCP, all everything was done, antiphospholipid, PTT, vitamin D, and all those enzymes were there, which I have already shown you. And again, this was a case of panhypopituitarism. Her last follow-ups, I had seen and started her a month back. In 1 month, her hemoglobin has improved by about 2 gram%. Her thyroid has not improved because I had not increased the dose of thyroid, fearing that once I start steroid, if I give thyroid, her metabolic activity will rise and she will have adrenal crisis. So I had not started. Now I have, after giving for about a month, I have started her, increased the dose of thyroid because it was a sub-dose. It was not correcting her uh, hypothyroidism. So now I have increased to, she was taking 25, I have increased to 62.5 microgram based on her weight, little bit on the lower side. She is again on the steroid replacement. Since she is 54, she does not require estrogen progesterone replacement. This is her hemoglobin. In 1 month, 2 gram improvement in hemoglobin without any iron, without anything. And WBC has improved to 4.3 because now the bone marrow is responding. I had also done erythropoietin in her case, which was little bit high, that showed that her kidney was functioning well. And despite EPO being high, bone marrow was not responding. Now bone marrow has started responding. She has started forming WBC, RBC. Now it is C, and within a month, her hemoglobin will be normal. Thank you. If there are any questions, then I can answer.
do you think is the takeaway message?
The takeaway message is when we become a specialist, super specialist, we dig deep, but our things become less, the horizon becomes less, more focused. So at times you have to invest in expanding your horizon also. And sometimes you, because the patient doesn't know where he is going to present to, whether he is going to gastroenterologist, gas patients will come with acute coronary patients will come to you because he doesn't know. So at times you have to expand your horizon, and when you get the such cases, you should not stop. That is what I would like to say. Don't stop investigating, and don't stop seeing at the investigation, the previous investigation. Many a times we don't see previous investigation and we keep missing. Here the clue is all evident in the investigation. Thyroid was giving such a clue which was getting missed for last 15 years. She was being investigated, bone marrow, everything was done. Every time her T4 was low, her T3 was low, her TSH was normal. That is why the thyroid dose was not being increased. That was first clue. And second, at 54 years of age, nobody bothers to take the history of. So history and investigations was giving all the clue. There was nothing so specific about the disease. Everything there else then depends on the investigation. You will investigate, you will find, you will treat. But if you miss, then you are off the track, then you can never get back there. So what I say is that focus on investigation, focus on previous investigations also, focus on history taking also, and then you have to take advantage of the newer technology, like I take like whole exome sequencing. If you don't do those, if you don't combine the technology with your the art, you will not get the result. Whole exome sequencing, whether it's karyotyping, whether all these investigations, you have to do it. Then you will get. And don't think of that investigation बहुत लंबा दिख रहा है, मरीज क्या सोचेगा. And never think of uh, the most of the problem happens that we want to make diagnosis within whatever we know. If patient comes to us, we think that the diagnosis has to be within the gastroenterology, which is not there. Pain abdomen is always for us enteral gastritis. It's not like that. You have to think outside also. Unless you think outside, then you might miss. Of course, it will happen only out of 100. You will get only 5 such cases. But these 5 such cases will be very rewarding. 95 cases you will still can do without, even without taking history, you can do with your investigations. But if you take these 5 will be very rewarding. So this is what I say, the art of medicine is still in the age of.
Just one thing to add to this. Many of us as gastroenterologists do look at thyroid functions.
Yeah.
And it is very, very frequently in the armamentarium of our investigation. And having worked in GP fusion, I used to emphasize on serum cortisol also.
Yeah.
Serum cortisol is something which many of us in our practice are not using routinely, but at times can be very, very rewarding.
In the last 6-7 years, I have at least 15 patients with adrenal deficiency on replacement. Of these, majority had been treated by quack for a long time. Somebody taking for 15 years steroids. Such patients and presenting to us with all vague symptoms. When we do, we find this secondary adrenal insufficiency. And additions also, I have 2 or 3 such patients. And there are many interesting things. Like you were talking about hyponatremia. I will tell you one patient. I wanted to present, but then it would have been very long. That patient of hyponatremia was being treated with usual natrize and again would come back. When I investigated, I found one more thing, that was hypomagnesemia was there, because I get KFT with all electrolytes, including magnesium. So hypomagnesemia was there, and that was marked. Again, patient had the same vague symptoms. These patients will not come to you with very specific symptoms, and only investigation will tell you. Only thing is you have to be on the right path of investigation, otherwise you will get distracted. So hypomagnesemia was so alarming in this patient. When I investigated, this came out to be Gittelman syndrome. And this patient did very well on magnesium chloride supplement, potassium portfolio supplement, dry nuts, dry fruits. But like any other patient, he was a defaulter. Sometimes he would not take. Ultimately, he landed in a very bad shape, and I don't know what happened to him. He was under my follow-up for about 2 years. non-compliant kind of a patient. Even magnesium chloride, taking magnesium chloride was difficult for him because he would start having some diarrhea. So he will stop, he will reduce the dose, and he will suffer again. And they will again come with magnesium of 1.2, 1.1, 1.3, that kind of magnesium. Sodium of 120, 115, 107. All these things were there. So that was a Gitelman syndrome. I could not investigate him with the genetic analysis because he was a poor patient, but that was the differential. And he was doing well. So therapeutic, if you see therapeutic things from magnesium supplementation, he was doing well. So you have to pick up these things and you have to investigate. Unless you investigate, you will not come to know. So, and I must tell you, this thyroid was taught to us by Dr. P.N. Singh while he was a tutor in RIMS. And he used to only teach thyroid. And we were very fond of him because he was a young and very friendly one. So he will take us on a ride with his Maruti car also at times at that time. So, and he would insist that you should only read from Harrison. So he would insist to that read from Harrison and read it multiple times. And that is what we had done. And these things, when they will pay, you never know. Shobha madam taught us maybe 35 years back, and that paid us today. So that is the kind of things that such he had taught what is secondary hypothyroidism, what is primary hypothyroidism, central hypothyroidism, all those things. So these things do work. So you have to have an eye. I have seen only one doctor here who always does free therapy for Dr. Pranav. He's always doing free T4. I don't do it all the time. When I have suspicion, then because of the cost factor, but he always do free T4 and TSH. This is the one person I have seen always doing this. Is it true or not? Because I keep seeing his patients also. So these are important things. If somebody had done free T4, maybe she would have been picked up earlier. Thank you.
Should I start, sir? Please. So, good afternoon, everyone. So, I will be talking about role of endoscopic ultrasound in gastroenterology. So, basically, this will be a kind of introduction and overview. I'm not going in details of so many procedures which are being done by endoscopic ultrasound. I am doing it for last 1.5 years. So, I would like to share few of my own cases, and it would be a basic overview. So I know all people are gastroenterologists here. This will be a basic introduction only, but uh, so basically endoscopic ultrasound is a combination of endoscopy with ultrasonography, and it is used to visualize and sample lesions of gastrointestinal tract, pancreas, biliary tree, posterior mediastinum, and retroperitoneum. And a broad range of frequencies from 5 to 20 megahertz is used in this, permitting a spectrum of depth of penetration and image resolution. So basically we have two types of a scope, that is a radial and a linear scope. Most of us use a linear scope nowadays. Radial scope is not being used often. The stations which commonly used are D2, that is distal to papilla, at the papilla, duodenal bulb, and gastric cardia, and on occasional cases, mediastinum. So how does endoscopic ultrasound help us in our day-to-day practice? Few of the cases. For example, a 32-year-old gentleman coming to us with recurrent episodes of acute pancreatitis for last 3 years. All cases were mild, none requiring ICU care. Previous workup was done for recurrent acute pancreatitis, ultrasound showing no gallbladder stones, there was no hypertriglyceridemia, serum calcium was normal. So, a diagnosis of recurrent acute pancreatitis was made. MRCP, which was done in previous episode, it showed no biliary microliths or gallbladder stones. Pancreatic duct was normal, 2.8 mm in head and 5 mm in body. No stones or calcification, that is, no evidence of chronic pancreatitis. This episode, the patient was admitted with us. The MRCP, which is written here, was done around 4 to 5 months back. So this time we decided to go for endoscopic ultrasound evaluation. And in this case, we can see that we can very nicely appreciate a dilated pancreatic duct in this case. Uh, and few hyperechoic foci are being seen and strands are there. The measurement of pancreatic duct done in this case was around it was around 3.9 mm. It's near the head of the pancreas, so it was slightly dilated. So a routine part of evaluation in such patients will be for biliary microlithiasis. So gallbladder screening was done, and we can see that the gallbladder can be very well seen without any microliths being visualized here. So basically, we are here dealing with a case of probably early chronic pancreatitis, although not all criteria is being met, but what we routinely see in our clinical practice is that most of these cases of recurrent acute pancreatitis are actually early chronic pancreatitis cases, which eventually turn up over the years with the full-blown chronic pancreatitis features. So these are the criteria which we use where parenchymal abnormalities and ductal abnormalities are being used. This is the conventional criteria where hyperechoic foci, strands, lobular contour, and cyst make the parenchymal abnormalities. Ductal dilatation, duct irregularity, stones, and visible side branches. These confirm a diagnosis. Although in this case, we could not find all criteria of chronic pancreatitis, but since the patient is having recurrent episodes of pancreatitis with a dilated pancreatic duct and few hyperechoic foci, so this we are dealing with a case of early chronic pancreatitis. Biliary microlithiasis screening endoscopic ultrasound is one of the best tests available. It can be missed even on MRCP. We know MRCP is not the best tool for diagnosis of gallbladder stones or biliary microliths. So those stones less than 3 mm in size, US scores above conventional ultrasound, and it is one of the most common sensitive tests. So patient presenting with recurrent episodes of pancreatitis, we are suspecting biliary etiology, probably endoscopic ultrasound should be an investigation if we are not getting other reason. Case 2, again, this is a 72-year-old gentleman, vague upper abdominal pain, anorexia, and weight loss. Ultrasound showing bulky pancreas with minimal surrounding inflammation. Amylase was 1.5 times upper limit of normal. A diagnosis of acute pancreatitis was made somewhere outside. However, a CT was done which shows a large heterogeneous mass in tail of pancreas. The pancreatic duct was not dilated. No peripancreatic fat standing. CA 19.9 was borderline. So this patient was referred for an US guided fine needle aspiration. So we can see here a large heterogeneous mass with a few areas of central necrosis here. So basically pancreatic mass. We could do a fine needle aspiration cytology of this patient with a 22 gauge needle, and this patient came to um, be an adenocarcinoma. So endoscopic ultrasound guided biopsy or FNA is the best modality for obtaining a tissue diagnosis, even if the tumor is poorly visualized by other imaging modalities, less likely to cause intraperitoneal spread of tumor, since the biopsy is obtained through the bowel wall rather than percutaneously. US guided FNA has a sensitivity of approximately 90% and a specificity of 96% for a diagnosis of pancreatic cancer. Uh, Especially useful in difficult locations. For example, this is a mass. We can see a splenic vessel is very close by to the mass. However, because of good resolution of today scopes which are available to us and the Doppler, an FNA was performed here. Again, this came out to be malignancy. So just an illustration of using the endoscopic ultrasound for diagnosis of masses at difficult locations. This is one of the cases I did yesterday. A case of a young female with a history of prior pulmonary tuberculosis had received ATT for 6 months. After that, she was doing fine for pulmonary tuberculosis. Now, this patient came to the pulmonologist with vague symptoms of fever at times and weight loss, with chest X-ray being normal. CT abdomen showed a peripancreatic lymph node, which was about 2 into 2 centimeter in size. So this was referred for a US guided FNA. Again, we can see a very well demarcated lymph node about 2 into 2 centimeter size in the periportal area. The portal vein can be seen below the lymph node, and US guided FNA was done. This case was done yesterday only. We are waiting for the result. A central necrotic area is also seen. So probably a case of tuberculosis, but we need to uh, rule out other etiologies like lymphoma also, since she has already received ATT. Now, a case of 35-year-old male, biliary pancreatitis, moderately severe pancreatitis. After initial discharge from the hospital, patient had pain and fever with leukocytosis and signs of sepsis. CT abdomen was done, which showed a ward of necrosis. We can see a large peripancreatic collection, which is compressing the body of the stomach. One important point is that for distinguishing walled off necrosis from the pancreatic pseudocyst, CT may not be the best way, because many times it is difficult to distinguish between necrotic collection from a fluid collection on a CT. So an MRI or even an abdominal ultrasound is better in this regard, and of course endoscopic ultrasound if it is available, because that determines the further treatment plan, whether we are going to drain it with a plastic or a metallic stent. So one of the revolutionary things that has come in endoscopic ultrasound is use of lumen opposing metal stents. So these are basically biflange stents with a coaxial force, and they are able to oppose the two lumen. Because of availability of such stents, the armamentarium of gastroenterologists in different um, interventions has increased a lot. So for that patient, an US guided drainage of ward of necrosis was done. This is a case done by us few months back. We can see here the cyst is being punctured with a 10 French catheter. It is a hot exhaust stent, and the stent comes mounted with the delivery system. It is a single shot, and we don't have to exchange the wire here. After initial puncture, the internal flange of the stent is deployed inside the cavity, and this is the endoscopic picture. Often after a drainage of a walled off necrotic collection, there can be a clogging of the stent due to necrotic debris, and the patient may actually require a few sessions of endoscopic necrosectomy, which can be done with an upper GI scope. With few cases that we have experienced, putting a nasocystic drain can be really helpful, because many times the patient after initial drainage will go in sepsis. So if you put a NBD catheter inside the cavity, and flushing of that catheter with normal saline or with antibiotic solutions really helps in further necrosectomy. This is a case we did last week only. Another ward of necrosis, we can see a lot of necrotic collection inside. This again was drained with a lumen opposing metal stand, uh, puncture followed by deployment of the stent inside. The patient was discharged 3-4 days back, and the patient is now doing fine. Did not have any complication, and till now he has not required any necrosectomy, but we have called the patient on follow-up. Peripancreatic pseudocyst, again, we know now it's becoming a routine procedure of draining the cyst with a plastic stand, which can be done both by US guidance or ERCP, but ERCP scope, but nowadays it is preferable to do within US scope. Post endoscopic drainage, the next day only the patient has excellent improvement. One of important indications of utilization of endoscopic ultrasound is in the setting of acute pancreatitis. For example, here we have two similar cases of 40 to 50-year-old female presenting on day 2 of pancreatitis. This is a common scenario which we come across, that in most of these patients, initially there will be raised bilirubin and SGPT, SGOT. However, if we wait and repeat it on day 3 or 4, we see that invariably the bilirubin comes down, and it's most of the cases the stone passes off, and ERCP is typically not required. But in some cases, when the patient, as per the ASG guideline, ERCP in acute biliary pancreatitis is recommended only when the patient is having cholangitis, the patient is having fever sepsis with rise in bilirubin, typically more than 4. So, case 1, the usual scenario, we should not go for ERCP in such cases, which will be, I think, more than 95% of the cases. Only 4 to 5% of the cases, an ERCP will be required when the patient we suspect is in cholangitis. So for CBD stones, endoscopic ultrasound has a sensitivity and a specificity of approximately 98%. It is more sensitive than MRCP for distal CBD stones, sludge and stones, which are stuck in ampulla. A systematic review of RCTs compared endoscopic ultrasound guided ERCP with ERCP alone for detection of bile duct stones. Patients randomized to EUS were able to avoid ERCP in 67% of the cases and had lower rates of complications and pancreatitis. So I think we also see in our routine practice that patient comes to us with a choledocholitis, small CBD stone. Patient has got an MRCP done, and the patient is called for ERCP after 2 to 3 days. When the patient presents to us, the patient is having jaundice, patient is having severe pain. And on the day we are doing the ERCP, it's quite often that we see the patient has symptoms has gone, and the bilirubin has come down. But obviously, we are not going to repeat an MRCP every second day. In such scenario, when we do not have a facility of this equipment, most of us would proceed for ERCP, and probably we do not find any stone, and it will be a negative procedure. So in such scenarios, I think doing an EUS before ERCP saves the patient from a procedure which has got inherent risk of complications of the tune of 5 to 10%. So that we try to do it routinely, that in suspected cases, at least put an EUS scope and screen for bile duct stone before proceeding to ERCP. We know ERCP is a procedure which is not without risk and complications, and so it should be utilized in that manner. For evaluation of distal CBD and head of pancreas, endoscopic ultrasound is an excellent modality. It is just a case of normal CBD here being demonstrated. The upper anechoic structure is bile duct, and the lower anechoic structure is portal vein. The station is duodenal bulb near the head of pancreas. So again, a case of um, recurrent epigastric pain. Even MRCP, this is a real case which we saw last year, that MRCP was done actually twice in this patient. The patient has recurrent episode of pancreatitis but could not pick the CBD stone. In such cases, endoscopic ultrasound was done. A small stone was detected and was retrieved with ERCP. One of the main indications of endoscopic ultrasound is evaluation of pancreatic cyst. Cyst with increasing use of imaging modality in pancreas is quite a common finding now to the tune of 10 to 15%. So as per WHO classification, the cysts are classified in serous, mucinous, and IPMN. Endoscopic ultrasound is an excellent modality for evaluation of pancreatic cyst or pancreatic cystic neoplasms. This is a busy slide, we all know this, but just for um, a reference that more or less cysts are of two types, serous and mucinous. The serous cystic neoplasms are usually benign. On the other hand, mucinous cysts are of malignant potential, including IPMN. So, evaluation of cyst morphology, including size and presence of mural nodules or solid components, presence of a dilated pancreatic duct, or other worrisome features, we go ahead with do a cystic aspiration, sending the fluid for amylase, CA, and cytology. On the other hand, if the patient has cyst with benign symptoms, it should be followed up. Other innovative modalities which are being done with endoscopic ultrasound is an endoscopic ultrasound guided biliary drainage, which can be a choledochoduodenostomy, which can be done from the duodenum, or a hepatogastroscopy, which can be done by placement of metal stent in case of malignant biliary obstruction. Useful in those cases with duodenal obstruction and where ERCP is not possible. Sometimes the patient is having acute cholecystitis, the patient is not fit for surgery. In that cases, this procedure can be life-saving, that is US guided gallbladder drainage. It's not a difficult procedure if we have the equipment with availability of lamps, and the patient can be saved from sepsis when the patient, particularly used for in those cases where the patient is not a candidate for surgery. Submucosal lesions, again, an important indication of for evaluation with endoscopic ultrasound. The layers of the GI tract are very nicely seen with the interface created with fluid. Uh, just to basically remember, the black structure is a muscle. That is, the first black line is a muscularis mucosa, and the second black lining is muscularis propria. So the five layers can be very well seen, and evaluation of some mucosal lesion with endoscopic ultrasound is very helpful. Like leiomyoma usually arises from the second, third, or fourth layer, and it is homogeneous and hypoechoic. On the other hand, lipoma, a common finding, is a hyperechoic structure, usually arising from the third layer of the wall. Gist, aberrant pancreas, and varices. Many times we see a bulge. Ectopic varices is differential there, then endoscopic ultrasound can be used. One of the latest interventions which is being done is endoscopic ultrasound guided gastrojejunostomy in malignant gastric outlet obstruction for palliative care, and this can also be done with the use of lamps. I have not done it till now, but just for a diagrammatic representation. Another useful uh, indication is US guided coiling of gastric varices, because many times the varices are very big in size. Injecting so much amount of glue can be difficult. Risk of embolization is there, and complete obliteration may not be achieved. In that case, the coiling of gastric varices along with the glue injection is done. Evaluation of mediastinum, another indication of endoscopic ultrasound. Here I have put two pictures. On the left side is a subcarinal space with a small lymph node. On the right side is a aortopulmonary window, again showing a necrotic lymph node. Very helpful nowadays in staging of lung cancer and suspected tuberculosis, where we want to obtain the tissue. Thank you. So, is there any question that I will answer? What are the common complications you have faced during your experience with POS? So till now, as such, I have not faced myself major complication, but I think while doing US, one of the important thing is while inserting the scope. at the upper esophageal sphincter, one should be careful because we know there is a risk of perforation with the scope. Second, while doing an FNA or FNB, if we are using a higher gauge needle like 19 gauge needle, sometimes we use for biopsy, then the risk of bleeding is there. But with the 22 gauge needle, I think usually we do not have any complication. Even if we puncture a small vessel, unlikely to cause a significant bleed. During placement of these stents, mal-deployment of the stent, uh, particularly the outer flange that is on the gastric side, that is a problem. Puncturing is easy, deploying the inner flange is easy, but while we pull out and we deploy the outer flange that is towards the gastric side, the mal-deployment inside the peritoneum, it can be catastrophic complication. So these are the things which I think.
Yeah, right time for me. Okay, so we'll be discussing about approach to functional dyspepsia. So coming to the overview of topic, we'll be dealing about introduction, epidemiology, types of dyspepsia, what are the etiology, pathogenesis in brief, endoscopy, what are the indications in dyspepsia, H. pylori testing and treatment, role of proton pump inhibitors and prokinetics, and finally the summary part of that. So it is very commonly encountered symptoms and it is very commonly encountered in day-to-day practice in OPD. The word dyspepsia is derived from Greek word dys and pepsi, that is difficult digestion, and it is the symptoms are localized to the epigastric region, and dyspepsia is any upper GI symptoms that happens for more than equal to 4 weeks, as per the American College of Gastroenterology guidelines. The common symptoms are upper abdominal pain, discomfort, nausea, and vomiting. Although it is not associated with any increased mortality, but it affects the quality of life, cost, and healthcare burden. So the epidemiology, you can see it is like a pandemic present all over the world. India is contributing almost to the prevalence is 30.4%. The highest is around in the Arabian region, like 60.1%. The common symptoms are epigastric pain syndrome that includes epigastric pain and burning sensation in the epigastrium that may be meal induced or may be empty stomach. And the second one is postprandial discomfort syndrome that includes postprandial fullness as well as early satiety. So there was two studies, major studies done for this dyspepsia evaluation. In the rural part, it was done by Dr. Yushi Gosal, and in urban population, it was done by SAH, SSA. It was found that it was more prevalent in the urban population than rural population. And the combination type, that means both epigastric pain syndrome as well as postprandial discomfort syndrome, was more common in either of the population. It was 64% in Gosal yeah, study, while it was in rural study, it was 50%. The postprandial discomfort syndrome was commoner in the two. It was almost 27% in the rural population and 33% in the urban population. So we can see the most of the symptoms are more common in the urban population. There were some other feature like IBS overlap and heartburn, which was although associated but was not in the diagnosis part of the dyspepsia. So the coming to the causes of dyspepsia, the if the patient is coming with the symptoms and there is no investigation as such, it is called uninvestigated dyspepsia. And further on history part, examination part, and further investigation, we find out whether it is organic or functional. Organic may be further classified as it is gastrointestinal cause or non-gastrointestinal cause. While if we are not getting any cause after doing all the workups, then we can say it functional dyspepsia that is contributing maximum of the cases. Earlier, the functional dyspepsia was called non-ulcer dyspepsia, and now it is called disorder of gut-brain interaction. So these are in a brief the causes of organic dyspepsia. It may be luminal, it may be pancreaticobiliary. Luminal common causes are H. pylori infection, peptic ulcer disease, GI malignancies, while in pancreaticobiliary cause, it may be pancreatitis, pancreatic carcinoma, gallstones, or sphincter of Oddi dysfunctions. So, to whether what type of it is, then in for to evaluate, we have to do the physical examination part, symptom severity, and lab abnormality and ultrasonological finding. This will tell what type of abnormality or organic problem we are dealing with. So what are the non-GI cause of dyspepsia? This is also important part because many patients with diabetes are there in the population, and they are contributing a lot of symptoms of dyspepsia. Other than that, hypothyroidism, organ failure, pregnancy, and many of medications like iron supplements, sometimes antibiotics, they contribute to the symptoms of dyspepsia. So coming to the round 4 criteria for functional dyspepsia, I think most of the our colleagues are aware of that. Like it is more than one of the following symptoms like bothersome postprandial fullness, early satiety, epigastric pain, and bothersome epigastric burning sensation. More than one of the feature is present, and there should be no evidence of structural disease found on endoscopy that is likely to explain the symptoms. And The criteria should be fulfilled for the previous 3 months. The symptoms should be more severe in the previous 3 months, and the symptom onset has to happen 6 months prior to the diagnosis. Coming to further subclassification, diagnostic criteria for postprandial discomfort syndrome or distress syndrome. It must include the one or both of the symptoms at least 3 days a week. That includes bothersome postprandial fullness, bothersome early satiety, and there is no evidence of organic, systemic, or metabolic disease on routine investigation as well as endoscopy. And similarly, the criteria should be fulfilled for last 3 months, but the symptom onset should be at least 6 months prior to the diagnosis. In this, I would like to say that the symptoms should be severe enough to impair the usual activity, and it should be severe enough to finishing a regular size meals. There is supporting criteria for this also, in which the postprandial epigastric pain, burning, epigastric bloating, excessive bulging, and nausea may be present in this case. And vomiting, if there is recurrent, it should warrant investigation for other causes of disease. Heartburn, which is a common symptom, is not a classical symptom of dyspepsia, but can often coexist with prandial discomfort syndrome. Those symptoms that are relieved by evacuation of feces or gases should not be considered as a part of dyspepsia symptom complex. And other individual digestive symptoms or group of symptoms from GERD or gastroesophageal reflux disease or irritable bowel syndrome may coexist with prandial discomfort syndrome. Now coming to the second subclass, that is epigastric pain syndrome. It must include one or both of the following symptoms. That is usually at least one day per week. In the previous one, it was 3 days per week, and the epigastric pain syndrome, it should be even one day per week is sufficient to classify as epigastric pain syndrome. In which the bothersome epigastric pain, bothersome epigastric burning sensation, and there is no evidence of any organic abnormality, even including the routine investigation as well as endoscopy. The supportive criteria is that the pain may be induced or relieved by ingestion of meals, may occur during fasting, and postprandial epigastric bloating, belching, or nausea may be present in this. And the in this also, if there is persistent vomiting, it should, like other cause, it should not be included in the evaluation of dyspepsia. Heartburn is not a symptom of dyspepsia, but often coexist with epigastric pain syndrome. Sorry. So this is in the summary, the functional dyspepsia room 4 criteria. We have got four subtypes in which they are broadly divided into two major subtypes: postprandial discomfort syndrome, early satiety. I'll not go, not repeat it again. So the types of functional dyspepsia, the prevalence wise, the majority are postprandial discomfort syndrome. It is almost 38% of population, while the epigastric pain syndrome is almost 27%. We in some subset of population we got overlap of this, that is 35% population, while GERD or irritable bowel syndrome may coexist in 32% and 14% of the cases of both. Coming to pathophysiology in brief, the common pathophysiological factor in dyspepsia is acid level, increased sensitivity of duodenum to the acid secreted by the stomach, dysmotility, H. pylori infection, which is very common in India, hypersensitivity of the intestine or visceral hypersensitivity. Many times, psychiatric issue like depression, anxiety are associated with the symptoms, and the duodenal inflammation is also playing a role in the pathogenesis of dyspepsia. The severity of symptoms can be decided by either tissue injury, what type of tissue injury it is. It may be GI infection, antibiotics, and NSAIDs. While the perception per se also may be contributing to the symptom severity, like if there is child abuse, there is associated depression, there is associated anxiety that can increase the perception of the symptoms. So the symptom severity is decided by these two, the interplay of these two factors. So coming to the history wise, we have to ask for symptoms. We have to ask any background of any illness, systemic illness like diabetes, hypothyroidism, any history of drugs is there or not. How is the diet pattern of the patients? Any recent history of GI infection is there or not? And other stressful event or any stress, underlying stress is there or not? And along with that, we should definitely ask for alarm symptoms. What are the alarm symptoms? Like if the patient is having any sort of GI bleed, or anemia is there, or there is progressive dysphagia and or odynophagia, or there is persistent vomiting, unintentional weight loss, there is family history of gastric or esophageal cancer, palpable lump or lymph nodes on imaging abnormality, or a history of NSAIDs or aspirin with dyspeptic symptoms. Age 60 years and 40 years, I have written just to like evaluate further what should be the age cutoff for alarm symptoms in India. I'll discuss it in subsequent slides. And further on, we have to do the physical examination like body mass index, pyloric teres, lymphadenopathy, acanthosis nigricans, hepatosplenomegaly, ascites, and signs of suggestion of any systemic disease. Coming to investigation part, the routine investigation we have to do for complete hemogram, that if showing any low hemoglobin, raised DSR, that suggests of either malignancy or peptic ulcer disease. Renal function test, liver function test to know for the corresponding disease. Thyroid function test, blood glucose, stool examination is a very common test but less frequently advised to look for ova, cyst, occult blood, or H. pylori antigen. Ultrasonography of abdomen should be done in case suspected of pancreaticobiliary cause of dyspepsia. So, the very important question, who needs endoscopy in dyspepsia? First of all, those with alarm symptoms that I had already discussed, adenophagia, dysphagia, weight loss, or history of gastric or GI malignancy in family or himself, though they will definitely need this endoscopy. And what is the age cutoff for India? There were different studies in West as well as in East. Our the prevalence of dyspepsia in the Western population was 20 to 40%, while in India it is approximately 30%. It is variable in different part of the region, but approximately it is 30%. In Eastern population, it is 5 to 30%. The type of dyspepsia is more commonly postprandial discomfort syndrome. H. pylori prevalence is almost 80 to 90% in Indian subset of population. Gastric carcinoma, although it is documented to be less, that is 4.5 per lakh population, but it is underdiagnosed because of the like our health structure as well as decreased endoscopy rates and decreased diagnosis rates also. Carcinoma stomach in age less than 40 year is, in Western population it is less than 1%. In Indian population it is 14.4%. In Eastern population it is 15%. And the 5-year survival of gastric carcinoma is much lower in India than Western and Eastern counterpart. So, and the recommendation of upper endoscopy, so definitely it should be approximately equal to or more than 40 years in India, because we are more having resemblance with the Eastern population rather than Western population. And because we are having less diagnosis of gastric cancer and we are not picking up the early gastric cancer. So this is a chart which emphasize that early gastric cancer or early endoscopy should be done in population wherever we are having any either alarm symptoms or dyspepsia that is not responding to medications. So, what are the caveats in doing endoscopy in India? It is although not a very costly test, and usually patient to visit to the specialist once or twice. It is easily accessible. Cost is not very high. Opportunity to pick up early gastric cancer, and usually, if the patient is having normal endoscopy in last 2 years, it is not recommended to do it again. So coming to approach to investigation part, if there is uninvestigated dyspepsia, that is patient is having symptoms of epigastric pain, burning sensation, or postprandial discomfort, then we have to do a history examination, and then we have to find out whether it is organic cause or functional cause. And if the patient is having alarm symptoms in age more than 40 years of in India, we should do a upper GI endoscopy with rapid urine test and with biopsy if needed. If there is any finding, then it is organic dyspepsia. If both are negative, that is RUT is negative and biopsy is also negative, then we can assume it is a case of functional dyspepsia. If the patient is having no alarm symptoms but having history of dyspepsia, urea breath test or non-invasive test of H. pylori should be done, like urea breath test or stool antigen test. And if it is positive, then we can assume it as H. pylori associated dyspepsia. And if it is negative, then we can assume it is a case of functional dyspepsia. So, what should be the strategy? Like test and treat strategy is the recommended one for Indian population, and the non-invasive strategy is preferred, but it is not very commonly used. Particularly stool antigen test is a very important test that has got good sensitivity and specificity, but it is seldom done in our practice. But it can be done, and those patients who are not needing for endoscopy, and those patient like if the don't want any intervention in them, then in this case we can do the stool antigen test. In invasive part, we can do the rapid histopathology examination. Ideally, it should be the sample should be taken from antrum, but it can be taken from fundus also to increase the yield of the test. Ideally, before doing the rapid urine test or aspiratory examination, the patient should be off PPI and off antibiotics for 4 weeks. However, the negative test does not completely exclude the aspiratory infection. So coming to the rapid US test that we frequently do in our practice in endoscopy, we have to use validated kits, and RUT usually positive if the organism load is 5 bacteria per gram of the tissue. We have to stop PPI antibiotics 2 to 4 weeks before the test, although it is not practically possible most of the time. But during the we can ask the patient to continue the S2 receptor antagonist or antacid in between if there is ongoing symptoms. So we have to report at 30 minutes if the patient is the it shows positive color. But even if it is showing positive color, we have to wait for 24 hours, and then after that also the color change is not there, then we can declare it to be negative. What are the cause of false negatives? It is less H. pylori, cold room, intestinal metaplasia, GI bleed, or gastric cancer. Although false positive cases, theoretically they can say that those some organism that produce urease that can produce positive of H. pylori, RUT. So these are the common treatment regimen that we have been using since long. Standard triple therapy that is frequently prescribed, although the kit what they we use have got less dose, that is 750 or 1500 milligram. That ideally dose of amoxicillin is 2000 milligram. The other regimens are sequential therapy, hybrid therapy, standard triple therapy, and concomitant therapy. That all have got success rate of approximately 85 to 90 or 94%. The newer regimen for that has been recently advised in according to ACG guideline. In those patients with treatment naive, we can use optimized bismuth quadruple regimen that includes bismuth, tetracycline, and metronidazole along with the PPIs. And in treatment experienced persons also we can use bismuth based regimen. While vonoprazan based regimen is also a good option in those cases in which the usual dose or standard triple has not worked. And one more important feature is that in penicillin allergic patients also we can use the bismuth quadruple treatment. Although availability is an issue, but some brands has come with the bismuth preparation in the market. So these are the dose schedule. You can see here what are the dose we can use. Bismuth citrate 120 to 300 milligram, that is QID. Tetracycline also in 500 milligram QID, and metronidazole also 500 milligram thrice daily. And rifabutin I have not been used ever, but I have used PCAB regimen in those cases in which the standard therapy has failed, particularly 3-dose regimen with vonoprazan. So the management strategy is for H. pylori infection is prompt upper GI endoscopy, age more than 40 years with alarm symptoms. If the patient is less than 40 years, no alarm symptoms, test and treat H. pylori infection. Empirical therapy usually delays treatment and is not very cost effective. And why and how to eradicate H. pylori? H. pylori has got effect of the gastric acid secretion and motor dysfunction. It has got small but significant relief, and it is cost effective. The main thing is that the prevention of peptic ulcer disease as well as malignancy, that is a which is a preventable part of malignancy that we should use if we have got H. pylori infection, either by invasive or non-invasive modality. All guidelines recommend H. pylori testing and eradication. So we have to confirm the eradication after completing the treatment regimen also. We have to ensure 14 days treatment standard regimen, compliance according to the local resistance pattern. So this is the normal protocol or for treatment of H. pylori. Normally, H. pylori treatment should be given for 2 weeks, followed by PPI twice daily for 2 weeks, and we have to stop the medicines for next 2 weeks, and then we have to repeat the non-invasive test for H. pylori infection. And if there was previous gastric ulcer, then we should repeat the upper GI endoscopy for evaluation of the ulcer regression. Coming to the treatment based on the pathophysiology, as we had discussed in the previous slide, there are different modes of there are different causes of pathophysiology of fungal dyspepsia. Like if the patient is having H. pylori, you have to treat the anti-H. pylori treatment regimen. While if the patient is having increased duodenal hypersensitivity or visceral hypersensitivity, in that case, we should use tricyclic antidepressant. Patient with psychiatric comorbidity, we can continue with tricyclic antidepressant or SSRI in a higher dose. And for acid suppression, we have to use PPI and S2 receptor antagonist. And for duodenal inflammation, we can give montelukast. While for the dysmotility part, we can use prokinetics. Like the patient more of postprandial discomfort syndrome patient, we can use PPI along with prokinetics. So this is the final flow chart for dyspepsia evaluation. If the patient is having alarm symptoms negative, H. pylori is negative, then which part of it is? Is it epigastric pain syndrome or postprandial discomfort syndrome? Then we have to do diet, lifestyle, and reassurance measures, because this is a long taking process. It may not respond to the PPI itself, because the diet factor we have to address, the lifestyle also we have to address. And if the patient is having epigastric pain syndrome predominant type of dyspepsia, in this case, empirical trial of PPI for 8 weeks should be done, and then we can stop it. If there is no response, then we can go for psychotherapy or PCA or tricyclic antidepressant or a combination. If patient is having postprandial discomfort syndrome type of dyspepsia, then empirical PPI with or without prokinetics for 4 to 8 weeks, and then we can stop it. And if it is showing no response, then we can consider for tricyclic antidepressant or psychotherapy. Coming to anti-secretory drugs, what is the rationale of that? Hypersensitivity, there is it was usually found that it is not the increased acid level secretion, but because of increased sensitivity of duodenum to acids, the patient is having symptoms. So acid induced gastric dysmotility, to decrease that, we have to use this anti-secretory agents that uses the because of impaired acid clearance and suppression of H. pylori. That is the main purpose of using anti-secretory agent, that is in form of proton pump inhibitor or H2 receptor antagonist. So although PPI has got uh, very good results in most of the cases of acid suppression and dyspepsia, but long-term continuation of PPI has got a lot of side effects that we can see, either bacterial overgrowth, atrophic gastritis, vitamin B12 deficiency, megaloblastic anemia, hip fractures, neutrophil dysfunction. Although we less frequently encounter, but we should keep in mind that we should not ask the patient to continue the PPI for an indefinite period. So coming to brief overview of proton pump inhibitors, the proton pump inhibitors are found to be better than H2 receptor antagonists than placebo. The standard dose is usually once daily. It is prescribed both in EPS or epigastric pain syndrome as well as postprandial discomfort syndrome. The it can be continued for 8 weeks. That is, it is found to be better than the 4 weeks regimen. If there is no improvement of the symptoms, we have to stop the PPI at 8 weeks. And we can continue with H2 receptor antagonist or antacids on SOS basis. The benefit is marginal, but the adverse drug reactions are found on long-term use. So there should not be no empirical anti-secretory agents should be used without any symptoms. So coming to refractory functional dyspepsia, if the patient is having ongoing symptoms despite giving treatment and there is no response after 8 weeks of treatment, and there is no response to the first line treatment like PPI and prokinetics, then we can consider it to be a case of refractory functional dyspepsia. In the second line, we should proceed, that is tricyclic antidepressants or psychotherapy, and we should rule out any organic cause by doing upper GI endoscopy if we have not done it before. Ultrasound abdomen is to be done if we are suspecting any pancreaticobiliary cause. The most important thing is the reassurance, lifestyle, and diet modification, because many times patients are very much fed up with taking a long-term PPI. So we have to always tell that it is time-taking process. You have to take care of your diet. And it's very, very important. Lifestyle, like you have to do, ask the patient to have regular exercises, better sleep, and take good care of his diet. Coming to diet, small frequent meals are a bit better tolerated in case of dyspepsia patient. We have to increase 3F, that is fruits, fluid, and fibers, and we have to ask the patient to reduce 3 O's, that is oily food, overeating, and odd time meals, and ask them to reduce smoking, spices, caffeine, alcohol, and avoid NSAIDs. Coming to the final slide of my talk, that is dyspepsia is a common and vexing problem. 70% is cause, of course, is due to functional dyspepsia. 30% is probably due to organic cause. We have to look for associated GERD symptoms or irritable bowel syndrome, and carefully rule out for the organic cause. We should do a prompt endoscopy if there is alarm symptoms. We should look for H. pylori infection or gastric carcinoma in the early stage. Test and treat if alarm symptom is negative. If H. pylori is positive, then we have to definitely treat it. APS, that is epigastric pain syndrome, PPI should be given once daily for 8 weeks, while in postprandial discomfort syndrome, PPI plus minus procardin can be given for 8 weeks. We should avoid empirical long-term PPI. The most important thing is that diet, lifestyle modification, and reassurance is the cornerstone of treatment. Thank you. I'll be happy to answer any question.
You mentioned about H. pylori, test and treat strategy in the Bristol affiliate. If I remember correctly, the incidence of H. pylori infection among adults in India would be about 90%.
Yes, sir. It was approximately 80 to 90% as per the.
And even the reinfection rates after eradication are above 70 to 75%. So how effective is the test and treat strategy, especially in relation to functional dyspepsia?
Sir, like a test and treat, because we cannot give medication for a indefinite period, and because of resistance pattern is quite high, particularly for the clarithromycin and metronidazole is quite high resistant in India. That's why the newer regimens like bismuth based regimen or vonoprazan based regimen are recommended, and we have to prevent the like further progression of disease if it is underlying H. pylori infection that is continuously going on and ultimately turning out to be any gastric malignancy. For prevention of that, and that's why repeated time in testing and treatment is required.
H. pylori RUT positivity is so high. How many times do you test and treat? That is the main question.
Sir, there is no there is no such cutoff, but
If you have studied patients for 8 or 12, and they say rejection rate over number needed to play. But in reality, the patients will have symptoms for such a long time. So you would never know that how many of them are going to be off PPI. Most of them will keep on taking PPI, irrespective, whatever we say. So when they have symptoms, they will take for a day. And second, the issue that was raised, the H. pylori, it's very difficult here because we never know when we have eradicated, never know when the reinfection has occurred. You cannot do endoscopy so frequently, you can't do this small H. pylori so frequently.
but sometimes compliance is also issue, sir, because of antibiotic.
Compliance. If patient is taken 2 weeks, some of these patients when they come up for a repeat endoscopy, they are still positive.
Yeah,
So,
agree, sir.
and that too the 1 gram IMC combination, because 1 gram combination has come. Earlier I used to write it separately, but now 1 gram combination.
Now it has come, sir.
So even with taking those medicines, so you never know, you cannot test the resistance within. It's very
It is difficult in our setup because we don't frequently do the resistance testing. So
this hygiene problem, we have so much of infection.
yes, sir.
What could we do? So we don't know. Comes like infection comes with keep treating. So we have to treat that.
We have to treat, but there is no.
Conjugality. So the topic of one of the debate slightly some years back that H. pylori is very whether to treat or not to treat. And there was no consensus, in fact, that some actually are.
Hardly ever we get a RUT which is negative. It's a rarity.
Yes, yes.
Rarity negative. It comes negative. It's a negative again. But it is plus. If you have a and even if it's negative, you have to trigger. Most of the times the way the search is contradiction, where you have managed to take that. Especially got some of the development experience. So even if you don't decide, you keep the direct symptomatic in that.
Like placebo effect is also always there, sir. Placebo effect is always there.
Right, which when you documented, you must treat it.
Yes, sir.
That is the problem here is not whether we should treat this is not. Problem here is how the frequency of infection, reinfection is so high. So how long do you keep treating and how frequently you should be testing? That's the main problem. There is one more concept. If you give a diagnosis to a patient of somewhere infected infection, then the anxiety level of that patient will be because you are fixing a diagnosis infection. इसके वजह से ऐसा हो रहा है तो उसके बाद सिम्टोमेटिक रिलीफ फंक्शनल रिलीफ तो बहुत ज्यादा रहता है जब आप उसको
इवन सर मैं बोलता हूँ पेशेंट लोग की इन्फेक्शन एक पार्ट है आपका डिस्पेप्सिया का, इट इज नॉट द ओनली कॉज, देयर मे बी मल्टीपल फैक्टर्स. दैट्स व्हाई they are more worried with that, right, sir?
Almost all available therapy everywhere they'll get RET done. Then AS pylori is class 1 carcinogen. Class 1 carcinogen.
We have to treat them.
There is a risk for postulate, as per the data has quality, 40 to 50% prevalence of PA stomach in investigated cases of dyspepsia in children.
Those cases are only because of the missed early changes. And
so the question is,
you have to be able to pick up intestinal metaplasia. If you can't pick up intestinal metaplasia, then you will not be able to see hydrated dysphagia. And intestinal metaplasia, till intestinal metaplasia, you can observe patient. But you have to keep you diagnose and keep him under surveillance. But you should know how to see intestinal metaplasia, for which you need to do a very meticulous endoscopy. And also you should have the latest endoscopy.
No, the question is about letting not to treat or test to treat exactly. So once we have the concrete evidence of class 1 carcinogen,
if you have evidence, treat it, no doubt. But in India, the problem is today you have treated for 2 weeks. Now you don't know whether patient has eradicated, then if is eradicated or not. So you have to retreat, retest.
Sir, based on the data, triple combination therapy has an eradication rate of approx 70%.
Yes, so 30% you don't know which 30%.
With 30%,
so with 100% you will see. You will see eradication. You can only see either the blood test, urea blood test, non-invasive, or you do endoscopy. So you can detect 2 times. I agree. Then you have some reinfection. What do you do after? Because this H. pylori, the main mode is orophyta. And because of the hygiene issue, reinfection rate is so high. So how frequently? Because after 6 months, again you find, again you treat. So how frequently you do? So best is you pick up early changes. Of course you treat. When you find, you treat. But when you do endoscopy, do a meticulous endoscopy, try to find out intestinal metaplasia changes. And if you find intestinal metaplasia, keep those patients under follow-up. Tell them that you get it done every 6 months. When high-grade dysphagia, you have to do EMR or ESD of that. In India, it's very difficult. Yes, sometimes patients don't understand the implication. And also, picking up those subtle lesions are also, it needs little bit of training. You have to be biopsy to करना ही.
There are no easy answers. How many of us are confident in diagnosing gastritis or endoscopy? Very few.
Many a times, what we do when we see red spot, we see gastritis. Well, you have to look for vascular patterns. You have to look for the surface patterns. all those things. Even atrophy, very difficult to say. So that is why the Paris protocol has come. But then what I do as a compromise, I can't take 5 biopsies, 5 different biopsies, 5 data, because it will be too costly, more than the cost of endoscopy. So what I do, I take biopsy from 5 points in the Paris. That's a compromise, of course. And then send it. In case it comes positive, then I am sure that it is out of these 5, at least one was positive. Then I am looking for those 5 points. Where was it? Or where is the changes like? Because 5 separate biopsies is too costly. Even if it is 700 rupees, 2,500 will be the biopsy cost. So that is what I do in my practice. Other than H5. And then you have to document all the picture at least. Answer when you see near the pylorus, then you come on the lesser curvature, then you come greater curvature, anterior, posterior. You have to see separately. Then you go to the incisura, then you see all the incisura, the lesser curvature, greater curvature side in the middle. You document those with the photographs. Keep it in your record so that you can compare it afterwards. But that is not possible here. When you are doing 10 endoscopies, 5 endoscopies, that's the difficulty. In Japan, they pick up these things only because the person doing upper GI is only doing upper GI throughout with 190 4%.
Oh, thank you. I'll invite another person to Dr. Sagat. Yeah. Hi, Dr. Sagat, the eminent pediatric gastroenterologist, will enlighten with his talk now.
Thank you, seniors. Almost all of my seniors, only one or two will be my colleagues. So thank you for giving me the opportunity. So today I will be discussing a little bit of pediatric versus adults and some new changes which are coming in here. Our definitions is a coagulopathy based definition. It's not on encephalopathy based definitions. In adults, you need encephalopathy. In pediatrics, we can diagnose ALF without even encephalopathy because this PALF-SG group is now it's not working. Okay. So this definition has been well accepted worldwide. Now people accept this one only. And we give vitamin K regularly. Like our definition includes vitamin K, we have to give, then only we have to give. In adults, most of the time, vitamin K is not preferred because it increases the bilirubin and then suddenly one a non-transplant candidate becomes a criteria, fits the criteria of transplant. And this acute liver injury definitions, that's within our definition of PALPSC, which is used in adults. In adults, this is the Western data. Most commonly, it's again paracetamol. And Western pediatric data is again mostly indeterminate, followed by paracetamol injuries and some of the metabolic conditions. But in India, the scenario is different. In India, these are the adult data as I could fish out. And what we can see still in India, it's hepatitis A and E are the most common. It's acute liver injury. Acute viral hepatitis is the most common, and rarely some small proportion as Wilson and small as AIH. And a large proportion was previously as indeterminate. Now that percentage is coming down because of the improvement in diagnostic workup. And the last one, the DLE is one of the significant causes. In children, it's almost similar, 70 to 80% acute viral hepatitis. small proportion of Wilsonians, and a large proportion indeterminate, and small amount of delay. So what we can see that India is different from the West regarding the etiology of acute liver failure, both in adults and children. And what is scenario in Jharkhand is they have a hepatitis A and D, and then there is herbal drug induced liver injury. So this is the most common scenario what we face in our day-to-day life. The scenario that in adults versus children and in India versus West is that usually we have a normal premorbid liver. Then there is an exogenous agent which is viral hepatitis A, E, B, or some drugs. There is an immune response which is mostly cytotoxic T cell mediated. Then there is a massive hepatic necrosis. Then there is liver failure. Wilson is a different scenario because it's already overloaded with copper. Then there is secondary mitochondrial dysfunction, and that is leading on to sudden necrosis and apoptosis, and that is causing liver failure. But in most of the time, the premorbidly the liver was normal. In adults, the diagnosis of Wilson's is comparatively easier because of these Corman ratios. Almost 100% sensitivity was in the original studies. But in children, it's quite difficult. That was in one individual patient data meta-analysis of 256 children published in 2020. The sensitivity of these two ratios was not so good as in adults, only around 50% or 70%. So we have difficulty in diagnosing Wilson's. But in presence of a cola-colored urine anemia, we have to suspect that this can be an acute Wilsonian crisis. And in acute Wilsonian crisis, we have to intervene early, otherwise that's a source of death. And the response to injury is there are two things. One is DAMS, one is SAMS. SAMS is suppression associated molecular patterns, and DAMS is damage associated molecular patterns. If it is the balance, if there is a well balance, so it will lead to recovery. If there is increased DAMS, it will lead to multi-organ failure and ultimately death. If it is SAMS will increase, it will lead to infections. So these cytokines we need to understand because in the following slides I will be discussing a little bit about plaques. So in ALF, we have two things. One is on one side, massive hepatic necrosis is ongoing, and on the other side, there is liver progenitor cells. So, whichever dominates, the clinical picture is determined by that. If massive hepatic necrosis dominates, it's death, and if it is liver cell progenitor cells dominate, that's survival. So, few So few will be going to recovery, few will be going to death. But in between, liver transplant may come in any point of in between this. So this one changes our natural history. That one need to consider. So that's why natural history we cannot study from the transplant centers. So this is I have already highlighted that A and E remains the most common in India, both in children and adults, and superadded indigenous drugs are the one which complicates the picture. And the premorbidly liver is usually normal. So this is pediatric data recently published from ILBS. What happens? They showed that in overall, when you consider the total group of liver failure cases, survival is around 50%. But these are the sickest patients. So they showed that in cases where there is almost 75% HE grade 3, 4, INR beyond 4.5, ammonia around 300 range, or most of them are ventilated, it's death, it's around 60% are dying, only 40% survival. So even standing in 2024, we have a good quality ICU care, we have wide use of point of care ultrasound, we have plasma exchange facilities, and we have liver transplant facility. Even with liver transplant, 60% are dying. So regarding therapeutic point of view, this is different between adults and children. What we have in adults, the original trial was very good, and so then came the recommendations. Okay, in adults ALF, we have to give in non-paracetamol ALF also. We have to give it. There is no controversy, and there is consensus among the guidelines. But in pediatrics, the data is not strong. This was from the King's College data. This was a retrospective data actually. So this is between 89 and 94, and this is 95 to 2024. They showed that the outcome improved after use of NAC, but the problem here is in between the quality of ICU care also improved, and we can see the age is more different. Whenever we go on to lower the age, less than 2 years, more kids, there is more of metabolic liver disease. So they in NAC does not work in metabolic liver disease, and they are even without NAC or with NAC, they have poorer survival. So this age is another criteria we have to consider. And this one trial only available in pediatrics that showed that its overall survival is similar, but transplant free survival was poorer. So we cannot just see start NAC and sit. NAC is not going to work in all. NAC will work in few cases and it will not work in few cases. So we use NAC in paracetamol, not non-paracetamol if it is early cases, it has come less than 10 days, or it is in the HE grade 1 or 2, not in 3, 4, it will not work. And then drug-induced liver injury, this was from the adult data only, subgroup analysis was there that showed the transplant-free survival improved, although the number was less. And mushroom or rat killer poisoning, it works. If it is less than 2 years, it's not going to work. If definite etiologies like autoimmune hepatitis or Wilson, it's not going to work. Now, the liver support therapy, we have fewer things. This is high volume plasma exchange, DP mass, MARS, SPAD, and ELAD. These are different modes of liver support therapy which has been studied here and there. So they one is biological. Then among the non-biologicals, there are plasma therapy and there is albumin dialysis. Plasma therapy is therapeutic plasma exchange, that is TPE. Then DP mass, then Prometheus system. And albumin dialysis, we have SPAD and MARS. The problem that all came failure. Mars, there were trials. These are all adult trials only. 2013, two trials came, all failure. Prometheus system, 2012, one trial failed. Biological system, one trial came, all failed in severe alcoholic hepatitis. But the picture changed after trials started coming from high volume plasma exchange. So this is the plasma exchange circuit. Quite a simple circuit. It's easily possible in any of the critical care units. So this is the mechanism. What does it do? It removes the cytokines. So now it's going back to those DAMPs and PAMs. The damage of the liver, of the kidneys, and other multi-organs are all mediated by the DAMPs and PAMs. So if you are able to remove the cytokines, probably there is some hope and you can stop the cytokine storm. So this is the first trial in adults, and that showed that overall survival was better in high volume plasma exchange group as compared to the standard medical therapy group. And this was both seen in intention to treat analysis, and even those cases where there was transplant criteria was already met, they also showed some improvement in. So they showed that these are the probable mechanisms. Now the SIRS is decreasing. All these pro-inflammatory cytokines are all decreasing. Pro-inflammatory neutrophils, they are all decreasing. Then came the standard volume plasma exchange. This is from ILBS by Dr. Rakhi Maiwal, uh, adult hepatology departments. The etiology was similar to our scenario. Hepatitis E and hepatitis E and hepatitis A were most common, and that showed there were improvement in 21-day survival even with standard volume. We may not be able to exchange 1.5 to 2 times of the plasma volume, but even if we do a single volume plasma exchange, that improves 21-day survival. And that showed again the mechanisms. This is the SIRS parameters that decreased up to day 5 and day 7. The DAMPs decreased from day 0 to day 5, but in the SMT group, they remained in the same level, and endotoxins also remained in the same level in the SMT group, but in plasma exchange group, they all decreased. So probably it's working in the correct as it expected. Then this is the pediatric data from the same study which I had shown initially. So they showed that even in the sickest patients, similar etiology what we face here. HIV was 52.3%, 46.2% in both the arms. They are propensity matched data published last year. It's working when we consider the all etiology groups among the pediatric acute liver failure cases. So these are the all etiology. Now, in lots of data is coming Wilsonian liver failures. So initially, one or two cases started coming. Then in 2020, they summarized all those cases and they showed that okay, among the 29 patients, 5 to 30 years of age, 17 survived with native liver with plasma exchange, 3 to 5 sessions of plasma exchange, and 12 underwent liver transplant. So that study started a flow of trials later on, and most of the data has come from ILVS in India only. So this one came in 2021. Even those who patient meet the new Wilson index. This is the Dhawan's modification of new modified criteria for transplant. That showed the 90 days survival is improving significantly, and that study was continued later on. Again in 2025, they published it, and they showed that by after three TP sessions, already the HE grades are coming down. Initially, HE 3, 4, 11, and 14 patients were there. Then 14, it was there in the 96 hours, and 24 in their SMT group. So more and more number of patients are going into encephalopathy in Wilson without plaques. And by 90 days whole cohort, they showed that the uh, survival with native liver is significantly different in the plasma exchange group. So all these contributions are coming from ILVS single center. That's the problem, not replicated from other centers, but these are rays of hope. And they showed that if we can start exchange early in the HE1 or 2 group, then the survival is excellent. So we have to catch hold of the patient, we have to diagnose it, and we have to start it. We cannot wait it till it goes into HE3, 4. It will not work in HE3, 4. Before either it is 0 HE or HE1 or 2. We have to start plaques. And this was the subgroup analysis of the previous study on among the all. It showed that hepatitis A etiologies, there are very good data even in the sickest patients, almost all encephalopathic ventilated children, it is working. Now this is adult data again from CMC Vellore. Drug induced liver injury, most of them are alternative medications what we face here. Some were antibiotics and some were antimicrobials, and they did low volume plasma exchange, 50% of the plasma exchange only, not 1.5 to 2 times, not 1 times, it's only 50% of the plasma volume, and they gave steroids together. So they showed that those even those meeting the transplant criteria, 63% are having survival. So this was in drug induced prime, although this was the primary result. Later on, they released did the same thing in severe alcoholic hepatitis. This is again the CMC Belur hepatology department. Again, plasma exchange, low volume plasma exchange with steroids. They again showed that survival is improving both in intention to treat analysis and per protocol analysis in severe alcoholic hepatitis, and the survival was at 1 year. And they continued with that study. They showed that there are two methods. I'm not a transfusion medicine specialist, but there are two methods they are using. Centrifugal one is better as compared to the membrane ones. This is the new one which came last year. They showed that it's again working even on 1 year follow up they did, and they are doing it even in rodenticides. We don't face it much here in south. Yellow phosphorus poisoning is quite common, and so Tamil Nadu ISG did this study and they showed that it's quite well, and they are even saying that even there is milder hepatopathy, mild SGOTPT, not yet in failure, you have to do preemptive plaques. And so evidence summary of plaques here is mixed etiology. We have data in adults and children both. Hepatitis A, we have pediatric data. Hepatitis E, we have the myol study, which has had few of the hepatitis E cases. Wilson's, we have pediatric data, 3 to 4 studies. Drugs, we have CMC Valor adult data, and alcohol, we have adult data. So probably it's time we have to consider this plaques as a part of our armamentarium in a management of liver ICU. So this machine is now very useful. It has all three one things. One has HD, one is CRT, and it can provide do plasmapheresis also. This is the triple function one. So now this will be used in liver ICU. Most of the liver ICUs has already, and the recommendations are also saying acute liver failure. Now it's a if you can do high volume, it's a category 1 indication. Even if you cannot do high volume, it's a category 3 indications. In West, the etiology is different. But in India, A, E, and drugs are most common. So probably this is justified in doing plasma exchange. And even if you could save one transplant by doing 10 plasmapheresis, I feel it's just quite justified. And the newer things which are coming, this is one trial in pediatric, obviously it is coming up in. So what they are doing, this is the indeterminate ALF when we have not find out any etiology. So that will be included in this group. And three arms, one is equine ATG arm, one is high dose methylprednisolone arm, one will be passive arm. So immunosuppression will be provided, and let's see what the result. So the hypothesis here is it's an immune mediated damage, although it's indeterminate, but it's an immune mediated damage. So this study will be completed in 2027 and will most likely show us the other features, because previously there were small scale studies in which it showed that this all this indeterminate liver failure are actually cytotoxic T cell mediated damages. There were high number of CD8 positives, CD103 positives. I didn't show that studies. So it's a larger version of that one. And that with that same hypothesis, it's a cytotoxic damage. So let's try immunosuppression. Then again, here, if we do transplant, it's same for pediatric and adult. If we do too early, unnecessary transplants. If we do too late, poor outcome even after transplant because of the multi-organ failure. So somewhere we have to decide between 72 to 96 hours. In pediatrics, what I want to highlight that we have a good amount of regeneration capacity. These two studies, one from USA and one from King's College. So what they did ApoLT. What they kept the native liver, but did a partial orthotopic liver transplants. In India, also it's being done now. So even by robotics, they have started doing it. So what they showed that at 10 years, the survival is quite good and native liver regeneration is almost 82%. So they keep on doing biopsies, ultrasound guided biopsies from the native liver. They show very good regeneration and they are starting withdrawal of the immunosuppressants. And that's showing even in 65% at the median 23 months post LT, they are able to withdraw the immunosuppression. So let the transplanted liver go away and the child may live with the native liver because the crisis period is now over. And the similar experience from USA again came. 92.3% native liver regeneration was documented in biopsy. And by the time of the publication of that study, 76% had already withdrawal of the immunosuppression. So it does not say that massive hepatic necrosis means all is gone. We still have hope, at least in Indian scenario, because our primordially our livers had some capacity to regenerate. So importance of etiology, this is a pediatric ones. I don't know what is the scenario in adults. Paracetamol hepatitis A or ischemic hepatitis, we don't need liver transplant. We have to give conservative support. Most likely we will be able to tide over the crisis phase. Wilson's and autoimmune, this will unlikely to survive without liver transplant. Indeterminate pulse and DILI. These are mixed injury patterns. We don't know what is actually going on inside the liver. In one study during the COVID period, this was adult study only by the Dr. S.K. Acharya group. That's what the multiple mechanisms are working. One is steatotic group, one is inflammation and biliary injury, all sorts of going in because of the herbal drugs. So they are unlikely to recover without transplant. And in mitochondrial, we face this mitochondrial HLH and HSV. They are useless. Even if we save the liver, other organs is going to damage. So it's between the eternal fight between one-sided massive necrosis, one-sided regeneration or dual differentiation. So conclusion in India and ELF mostly an acute event on a premorbidly normal liver. Regeneration capacity is there even after massive hepatic necrosis. And liver transplant is a palliative therapy with burden of lifelong immunosuppression. And sudden cost burden like almost 20 to 25 lakhs is there beyond affordability of 99% of our Jharkhand patients. So what we need is a dedicated liver ICU. At least we can try Plex. Thank you. What is the cost of Plex? Sir, it's around 10,000 only, sir. 10,000, maybe 12. There is a kit, complete FRSS kit, that's around 9,300. And you can add on few gloves, few FFPs. So it's the few FFP in. Yes, in PGI we used to get it free. वार्ड से ग्लव्स दे दिया, FFP फ्री में मिल गया, और किट इन्वेंट हो गया, फ्री में हो गया. Here it's costly, but it's affordable, sir. It's still possible. It's not impossible to provide it. No, sir. Yeah, that's it. And sir, in pediatrics, we can arrange FFP. Pediatrics, we can arrange. Our plasma volume is less, so we can arrange. And 3 to 5 sessions people have tried. We can give 3 sessions. Sir, these are similar things, but there is little bit of intricacies there. I am not going into deep into that one. There is a guideline by the apheresis group, and it is details mentioned what is therapeutic plasma exchange, what is plasma. Yes, sir. It's almost same, sir. It's almost same, but the volume is larger, so that's why we need a separate catheter for that one. In patients, what we did, if we are not able to do, we when we with central line we did it, we HD catheter insert करवा ली, उसमें से भी हो गया काम. Volume is less, sir. Volume, yes, sir. Yes, CMC CMC only one center is data. But in UA, recently last year only one data came from UK. Multiple multicentric data from UK. They said it does not work. And Dr. Phillips from Kochi is also saying it does not work. Does not work. Yeah, yes, sir. Yes. GB syndrome they are trying left and right. GB syndrome तो लगना है उसको अगले दिन तक होना है. GB syndrome वगैरह में काम तो कर रहा है. No, we didn't.
We had March in RR hospital when we started the transplant program. 2 patients only we had done. None of them were. I have experience in PMC, but we had March. So last period we did RD patients with sepsis, AKI, liquid relocation. Out of 13 patients, 3 liquid supply in the world. Out of 13 patients, was basically either the success and use the ever relaxation with the interest in the possibly. Past and past picture ज़्यादा हो जाता है. बहुत सारे it's bad. It's bad में थोड़ा कम costly. वही हाल तैयार है. सर बाकी सब almost failure है. Only plasma exchange में थोड़ा बहुत data है. ये सस्ता भी पड़ता है. हाँ, थोड़ा सस्ता भी पड़ता है और बच जाता है. बाकी सब में तो लोग अब ट्रायल करना भी बंद कर दिया. मार्च तो बंद हो गए. सब बंद हो गए.
So we'll have a brief panel discussion. Myself, Dr. Chandan Yadav, gastroenterologist practicing in Curesta Hospital. So we need some panel for this. I request Dr. Alok Chandra sir, Dr. Rakesh sir, and Dr. Mayank. He is MCH gastrosurgery here, practicing in Pulse Super Speciality Hospital. So please be on the list. Sir, please. So we have new guest, Dr. Mayank sir. He is a gastrosurgeon MCH, practicing in Ranchi. So we'll be discussing brief just in a nutshell. So this is the revised Atlanta classification for the definition of pancreatic fluid collection. So the content can be acute and chronic, defined on the duration of less than 4 weeks as acute and more than 4 weeks with well-defined wall as a chronic one. Fluid can be, if it is an acute clear fluid, it will resolve with pseudocyst formation, and if it is necrotic collection, solid and fluid, will lead to formation of walled off necrosis. So in first 4 weeks, we have an infected pancreatic fluid collection and infected acute necrotic collection. Both mandates the separate approach. So this is how this is. First one is acute necrotic collection, and the right side we have a well-formed pseudocyst. This is first one is sorry peripancreatic collection, and this third is we have acute necrotic collection. Almost more than 75% of pancreas have been replaced with necrotizing tissue with non-enhancing on CECT with formation of pseudocyst and AF foci after the 4 week of disease. So these are the certain indications of intervention in pancreatic fluid collections. So we have infected necrotizing pancreatitis not responding with conservative management, ongoing organ failure for several weeks. Exact duration is still no. We may have pressure effect in a form of gastric outlet obstruction, especially with large pseudocyst. Intestinal or biliary obstruction sometimes may occur. Persistence of symptoms like early satiety, intractable pain, not mandating repeated parenteral analgesic. Patients sometimes become opioid addict too, and disconnected pancreatic duct syndrome. So this is one case one. So we have a 55-year male, and diagnosis of acute pancreatitis was based on Atlanta criteria, classical pancreatic pain with amylase of more than 800. Ultrasound suggestive of bulky pancreas. So We'll proceed with conservative management with IV fluid.
Hydration is one of the most important. Hydration is one of the most important cornerstone of management of acute pancreatitis. And aggressive hydration, especially in the first 24 hours, is very, very essential. At least 150 ml per hour, and the best, I think, normal saline is there. Uh, if vomiting is present, then we can use antiemetics along with hydration. Um, Hydration till about 48 hours and even beyond will limit the extent or the progression of necrosis.
I just want to say one word in this one. कि, जैसा कि we were taught that hydration and analgesia are the first two pillars to treat a pancreatitis, and the hydration should be aggressive hydration. Nowadays, the thing has come up कि you do the hydration after looking at the IVC also. So you don't do overhydration. If you start doing overhydration, then you start again creating a problem. Number one, this thing has been mostly, they have been discussed by the critical care. Mostly they want to see the IBC and just go with the hydration. So their idea is also very good. Don't do overhydration. Number one, and number two, regarding fluid, I think RL. I think they are promoting more RL to the first 48 hours.
So hydration should not be aggressive, but it should be moderate with IBC guided.
IBC and urine output. That's the two criteria. If the urine output is good, your IBC is well hydrated. Don't go with the very overhydration.
So most of the patients who present in our centers, they are totally dehydrated, being treated with tramadol in the peripheral centers. So our first aspect, as Dr. Alok Chandra sir has told, so we go for an hydration, but not too aggressive. That may precipitate, we call volume overload, abdominal compartment syndrome. So question is that we have to monitor IVC. So hydration should be IVC guided. 10 ml per kg bolus. That's approx 600 ml bolus. Okay.
So what is important is what should be the diameter of IVC after hydration. So that should be at least 22 mm. If 22 mm is the IVC diameter, then you know that it is well hydrated. And you can do it bedside. It's very easy. The moment you put a probe on the abdomen, you will see IVC. And you have to see it in the intra hepatic part of the IVC. Why? Because of the abdominal movement with the respiration, the IVC
Collapses.
the diameter will change. So you have to see it in the part which is in the hepatic, intrahepatic part of IVC. So you just put a probe, see the intrahepatic part of IVC, and it should be around 22 mm. Then you know it's well made. And that is true for almost any condition, any critical care patient.
Now, as far as analgesia is concerned, any special comment?
We prefer, it depends on the patient. How, if needed, fentanyl infusion. That's the one which we can give. But many of our patients also respond very well. What I do, I add tramadol in the infusion fluid and give uh, diclofenac SOS. That also works. But if pain is there, you have to suppress the pain. That is the cornerstone, whichever method you use. But fentanyl is, of course, preferable if you can monitor, but it requires a little bit of monitoring, and these things are needed. Sometimes, because of the cost issue, we compromise it this way. But analgesia is an important aspect of the treatment.
So use of NSAID in a patient with a renal dysfunction should be taken cautious.
Yes, definitely.
If a patient is having paralytic ileus, use of opioid should be restricted, considered to NSAIDs. And being an sterile condition, we don't proceeded with antibiotic here, considering sterile till first 7 weeks. Now the patient enter into second week. So before entering into day 14, regarding the feeding, when to start with the feed?
The moment patient can tolerate. If he is pain free, if he can tolerate, you can start feed. The earlier, the better. And oral is always better. So if he can tolerate oral feeds, fine. If not, rice tube. If not, NG placement. Whichever way you have to feed. And if the paralytic ileus persists, patient can't take it orally or cannot tolerate NJ feed, rice tube feed, then you should put in a NJ feed and start feeding.
So does putting of NJ feed succeeds over nasogastric feeding in
There
acute
has been
pancreatitis?
randomized trial also. Dr. Ajay Kumar did it between NJ and the NG tube. They found that it was equally effective. But if there is a segmental ileus, NJ will not be tolerated. So that is what I am saying. If patient is tolerating oral, allow oral. Otherwise, NJ means NG. If that is not tolerated, then you do NJ. It's not that in every case you do NJ like a protocol. It depends. Your basic goal is to have internal feed, whichever way patient accepts it.
Ileus per se will not be early ileus, of course, you will not be feeding. But even when bowel sounds have not returned, giving fluids orally or by NG tube is in fact helps in resolution of ileus.
In fact, bowel sound is no longer a criteria. You will see the GI surgeons don't wait for for bowel sounds these days. That used to be one
Idea,
of the criteria earlier. No.
idea is that when we give enteral feeding, it suppresses the translocation of the bacteria. So the idea is to early start the feeding is that to limit that bacteria translocation, which will become more problematic in subsequent time. That is the thing.
So question is, should we start feeding in ileus?
If ileus is there, we should not feed.
Ileus, there are two types of ileus. One is segmental ileus and one is total paralytic ileus. If there is total paralytic ileus, you can't feed. But most of the time it is segmental ileus where they tolerate NJ feed. That is why when you that time you where the pancreas is there, only that adjoining segments of the jejunum is in ileus. Rest all are working. So if you try NJ feed, it would work. But if patient is not tolerating, of course you won't do. It all has to be clinically oriented, clinically guided.
Nice insight for segmental ileus. Usually we consider as a group pancreatitis component of group when there is inflammation at
They are the duodenum.
duodenum.
Yeah. And
So
that is why you get cut-off signs also,
cut-off signs.
because of the
So with the
segmental.
predominant of pancreatic head is involved in necrotic pancreatitis, we have a predominant. So we should look for the precipitating event of ileus. Patients remain hypokalemic, so adequate replacement should be done. Anyone having experience of prokinetic in a patient with acute pancreatitis and ileus leading to resolution with metoclopramide or so?
I don't think many people use, and neither do I.
As
Any
surgeon
experience?
prospectives, they people are fond of using prokinetic in post-op state.
Post-op period is something different. When we are doing surgery, something different. Here, if the whole of the thing is into the ileus. So actually, that ileus is because of all the cytokines and the mediators. So basically, I don't think so. It is going to give you a lot of matlab, positive outcomes using that.
Now the patient is having ongoing SIRS with a hyperleukocytosis, neutrophilic predominant. We have an ultrasound with a collection of 10 into 7 centimeter in peripancreatic area. CT is showing no any clear evidence of infection. What next? Patient is tolerating feed.
Continue conservative.
Continue conservative management. So patient has entered into second week, so we can start.
Surgeons.
The idea is that if there is a USG collection, okay, if the patient is tolerating feed, pancreatic, any intervention, delay. That's the dictum. So as much you delay, your intervention will be it will be more fruitful to you until unless it is very much needy for the patient.
So we are going to start antibiotic here.
No.
Patient is in second week of illness with leukocytosis.
Antibiotic has no role.
It's a very
After
contentious issue of using antibiotics in the second week. Just SIRS without any fever. I would agree with Dr. Rakesh. I will not start antibiotic.
Of late, even in acute necrotizing pancreatitis, they are not saying that you should start prophylactic antibiotics until proven infected, of course. But even in acute necrotizing pancreatitis, antibiotic use is being discouraged. So most of the people, though most of the people start in acute necrotizing, but you should resist from using, because when the need arises, you will not have those antibiotics to use. So it's better to wait till you can. And here I get also guided by sometimes differentiating between infection and the inflammation is difficult. So here what you can do, get CRP of course and IL-6 estimation, which is available in the lab. You can get IL-6 estimation and CRP and you see what the results are like. If you see it is predominantly inflammation related, then you should wait, because many of these patients will also have fever and people tend to use antibiotics very early. That should be discouraged. Yeah, Procal also. People use Procal, CRP, IL-6 combination, IL-6. So cost is a factor. So CRP is the first thing that we use. Then Procal, IL-6 combination you can use whichever way. So so that is why the consensus is don't use antibiotics unless you are pretty sure that it could be infective. Yes. And
So
at times
in
But
we
people
tend
are
to
using that.
at times we tend to use antibiotics, but I usually don't.
so we have a patient in second week with SIRS with a collection, no clear-cut radiological evidence of infection. We are managing without antibiotic and we are continuing. No. In second to fourth week of the illness, now we suspected SIRS was ongoing. So we did a CT. There was air in the necrosum. What next? Should we proceed with FNSC?
What is the organ failure status?
Only ongoing SIRS with air foci on CT without further organ deterioration. Only
I would
SIRS.
still not intervene and will rather use antibiotic at this stage and wait how patients is doing clinically. But that is for
That's the issue. Means if at all there is air in the necrosum that is suggested of infection, you treat it with antibiotics. If the patient is improving, go ahead with the antibiotics. If it is deteriorating, you have to do some intervention. Either go with PCD or you go with EUS, whatever you are having in that scenario. But you have to intervene if the patient is deteriorating. That's it. The idea of not wall forming is to drain it.
drain away the
More if you are not able to control with one of the therapeutic agents, you have to try. You cannot leave him slipping down away. You have to try something else. So if you have having two PCD, try two PCD, एक से निकालो एक से डालो, lavage it. That's the idea. तो जितना उसका जितना ये कम होते जाएगा कंटामिनेशन, उतना आपका एंटीबायोटिक, क्योंकि नेक्रोसम के अंदर तो एंटीबायोटिक का पेनिट्रेशन है ही नहीं, आपको तो कहीं ना कहीं से तो उसको हटाना ही पड़ेगा.
Any special insights, sir?
I agree fully, and these days it has become more and more easier. I mean, our radiologists are also becoming more confident in putting PCTs. We are becoming more confident in US guided, or even without US guided, we are becoming more confident in putting at least 2 to 3 plastic drains, stents. So not a problem. Antibiotics, and along with an intervention, possibly not waiting for 72 to 96 hours for antibiotics to act. We should intervene over here. No, those guidelines of delay, yes, delay is there, but those 6 weeks delay is no more applicable now. It is all dictated by the status of the patient and the status of infection.
so you don't do any intervention unless required. But if it is required, what do? You have only two options: PCD. No, FNAC, of course, that is to prove.
CT guided interventions are much easier today. I agree, ultrasound guided interventions, everybody may not be confident. CT guided interventions, I think most of our
You-
If your goal is conservative till possible, then what is minimally invasive, and then of course, lastly, surgery is there.
There are three routes. Either you go with the percutaneous route, or you go with the intraluminal routes, or you go with the peritoneal routes. So any other route, you have to achieve the target, and the target is to decrease the contamination. So if you think that there is a huge amount of solid component, it is not going to work with the small bore hole things. You go with the laparoscopy, suck it out, and you try to make it the things lower contamination side. Put through drains and come out.
So the timing of intervention, delay, delay. 4 week preferably gives the time for encapsulation of the necrotic collection. So we try till 4 weeks. However, if there is ongoing organ failure, deterioration in the renal function, deterioration in the sensorium, patient is becoming hypotensive. It's a time for early intervention too. Percutaneous approach is preferred. Even before 4 weeks, we have a life-threatening infection that is not being controlled by antibiotics. No, this was a topic which was being discussed. Procal guided antibiotic use in a patient with acute pancreatitis. It was a Procap single center study, patient blinded RCT, where the cutoff was PCT of more than 1 nanogram. And they started and continued antibiotic, and they checked on day 0, 4, 7, and weekly thereafter. So 45% of the patients in Procal guided care group were prescribed antibiotic compared with 63% in the usual care group. And there was no significant difference between the group in terms of the number of clinical and hospital acquired infection or adverse event. So it mandates judicious use of Procal guided can give one pacer here. उससे भी ज्यादा आता है हो सकता नहीं सर हम लोग जो प्रोकैल भेजते हैं ना वो सबसे सीरियस पेशेंट में लास्ट रिसोर्ट में भेजते हैं कि अब प्रोकैल एक बार भेज के देख लेते हैं तो इसीलिए उसका प्रोकैल बहुत ज्यादा आता है less than one. So we have procal guided rate can reduce the indiscriminate or liberal use of antibiotic. So this is acute necrotic collection with air foci on CT. The patient is. So we proceeded with antibiotic. So conservative approach with antibiotic, and when the fever is not responding, SIRS is not responding. So till what time you prefer to wait for percutaneous drainage?
As we discussed before.
48 hours.
No, 48 hours. Organ failure is not there. Fever is not an indication for any major intervention. You have already started antibiotics. Fever may continue even after the intervention because of the surge. So unless there is organ failure, unless patient is deteriorating, clinically you are seeing it's deteriorating, then you intervene. Otherwise, wait. Or except in a certain situation when you have a very well localized collection, you know it's a very less risky procedure to do, you can do. But I would rather wait. First principle is wait unless patient is deteriorating or developing organ failure, at least two organ failure. Then you intervene. Then you have the intervention has shown survival benefit. Otherwise, there has been no benefit. People have intervened before also, but there is no benefit of that intervention. So intervening or not, if you see from the benefit point of view, will depend on how much organ failure is there, patient is deteriorating or not. But sometimes we tend to, because of the pressure, कि कुछ करना है, बुखार जा नहीं रहा है, 20 दिन हो गया, बुखार आ रहा है, then you have to, that pressure builds up on the treating physician also.
So we'll proceed with minimal invasive intervention thereafter with persistent. Invasive intervention where possible delay until at least 4 weeks for the collection to become one-off. This should be tried as far as possible. So this is what the step-up approach or open necrosectomy as done earlier for necrotizing pancreatitis. So well-proven fact, we go for a step-up approach. Antibiotics followed by percutaneous drainage if indicated, or endoscopic transgastric drainage if walled off, followed by retroperitoneal necrosectomy. So step-up approach major complication rate was 40% versus 69 in traditional, and drainage alone was successful in 35% with same mortality. So this is what the superiority of step-up approach. We have a no difference in the recurrence or recurrent or chronic pancreatitis. There was no significant increase in the intervention following endoscopic step-up approach in terms of endoscopic or surgical intervention, and cost and quality of life equal. So step-up approach was found to have a superior on short-term and long-term goal. So now the question is about the immediate versus postponed intervention for the infected necrotizing pancreatitis. So most of the people, we are in favor to postpone the intervention as far as possible till the wall get matured,
Yes.
unless and until indicated clinical.
Indication of clinical is that if the organ is deteriorating, if the sir has said two or more organs are deteriorating, they have to do something. If the organs are not deteriorating, you put on antibiotics and wait to get the wall mature, because that makes your further intervention more easy.
So the immediate drainage is not superior to the delayed drainage. The less number of invasive procedure in delayed drainage, because all the necrosome gets collected here and walled up. 39% of the postponed drainage group ultimately didn't require further drainage. So there is a chances of a spontaneous resolution too in walled up necrosis. The long-term outcome of immediate versus postponed intervention in a patient with infected necrotizing pancreatitis, the pointed multi-center trial. During long-term follow-up of 51 months, a postponed drainage approach using antibiotic in patient with infected necrotizing pancreatitis resulted in fewer intervention as compared to immediate, and should therefore be the preferred approach. So what we have discussed. So this is what antibiotic in infected pancreatic necrosis. Significant number of patients treated with antibiotic don't require drainage or necrosectomy. Approx there is a resolution rate of 35% by Pramod Garg from AIMS New Delhi, and in Western data we have 39% of spontaneous resolution in infected pancreatic necrosis. So this is the basic dictum, the punchline: delay, drain, and debride. So debridement should be the last one. So we should approach infected necrotic collection, which is not improving with 48 to 72 hours of antibiotic treatment. Patient is having continuous fever, raised TLC, high oxygen requirement in this case in 3 to 4 weeks of the illness. So we had to put a PCD here. Then patient improved. So this is another case. I think we should stop. Yes, sir. Yes. Thank you, sir, and thank you all the panelists for actively involving. Sir, vote of thanks कर दीजिए आप. Chairman आपके chairman. One second. So I request Dr. Ravi sir to give vote of thanks.
Uh, I thank you all my seniors and very eminent gastroenterologists from all over Jharkhand for coming here. And I especially thanks our pharma partners for supporting us in this midterm ISG con organized by Jharkhand chapter. Thank you.